just connecting. Okay, we are ready.
Shall we? Ready to go?
We're ready to go.
All right. To quote Yogi Berra, I'm experiencing deja vu all over again and would like to call this meeting to order. Ms. Mayville, can you please call roll?
Yes, sir. Good morning. I will start with our voting commissioners. Dr. Packham,
Here.
Dr. Barron,
Here.
Teresa Bohannon,
Here.
Babette Bond,
Here.
Jessica Flood,
Here.
Flo Khan,
Here.
Dr. Khan,
Present.
Yarleni Roa Dugan,
Here.
Sean Shaner,
Here.
Doc. Sorry about that. Mason Van Howling. Mason Van Howling. Can you hear me? Can you hear me?
Yes.
Okay, sorry, I think we're having technical issues still. Insurance Commissioner Barbara Richardson. Oh, sorry, these are our non-voting commission members now.
That's fine. I'm here.
Barbara Richardson, Jamie Sawyer on behalf of the Silver State Health Exchange,
Here.
Director Richard Whitley,
Here.
Executive Director Cholhajian,
I'm here. Thank you.
and Chief Deputy Attorney General Greg Ott. Are you there? Greg
on.
Ott? Okay. Mr. Chairman, that concludes our roll call and we have a quorum.
Thank you very much. We've lost a little bit of time, so I'd like to proceed with public comment and ask those presenters to limit their comments to agenda items and to please keep those to no more than 3 minutes. Sarah, go ahead.
Okay, great. I'm looks like our first person up is Brett Salmon. I'm going to allow you to talk now.
Yes, can everyone hear me okay?
We can.
Awesome. This is Brett Salmon. Thank you, Chair Packham and members of the commission. I'm with the Nevada Healthcare Association, and my association represents skilled nursing facilities and assisted living facilities throughout Nevada. And thank you all for the hard work that you're going to be doing today, kind of discussing the impact of COVID-19 and how the impact that it's had on healthcare providers. And the members of our association have also really been on those front lines protecting residents from COVID-19. And we're obviously very proud of, like all of you are, of the caregivers and administrators that have worked so hard during the past several months. And I just wanted to address just 2 little quick issues. One being personal protective equipment. As we've been dealing with this pandemic, PPE has obviously been a big issue for everybody, and it's been an issue for us as well in long-term care. Currently, we have kind of a tiered system in how we distribute the personal protective equipment. And what we learned kind of through in long-term care is that nursing facilities and assisted living facilities are typically a tier 2 in emergency plans. And so if we had the hospital system overwhelmed during our most recent pandemic, we would have had a real problem with a bottleneck where skilled nursing facilities wouldn't have had adequate PPE to handle any discharges from the hospitals. And so that's an issue that we are hoping that the commission would look at a little bit closer on how PPE is distributed to make sure that it's sort of spread maybe in a different way. And then just finally on the sort of the statistics and how long-term care is done, I wanted to get out sort of to the commission a little bit about how long-term care facilities have done through this process. Obviously, we care for people, we don't care for numbers, but it gives you a little bit of perspective. We have 64 total skilled nursing facilities in Nevada. 40 of them have had COVID in them, and 6 of those buildings have been entirely recovered from COVID. So currently we have 53% of our skilled nursing facilities have COVID in it. And with our assisted living facilities, there's 382 in the state, 32 have had COVID, 8 are fully recovered from COVID, and that's 6% of total assisted living facilities have a COVID case in them currently. And so, you know, one case is too many, but we're very thankful that we haven't been hit as hard as sort of some other states that you've read about. I want to thank the commission for hearing the input of healthcare providers today. You're going to hear some great testimony, and I look forward to hearing it as well. And long-term care facilities would also love an opportunity maybe at a future meeting to kind of share with you a little bit of what we've learned through this process as well. And thank you for your time.
Thank you. Next, Sarah.
Great. I actually have Lisa Durrett.
Thank you, Sarah. Good morning, guys. I am Dr. Lisa Durrett, woman of a couple of hats. I'm coming on behalf of being chair of the Commission on Mental and Behavioral Health in Nevada, but I'm also a full professor of psychiatry at UNLV School of Medicine. And I want to just spend a minute or two talking about telehealth. And it's an area about which I have a lot of passion. It's on your agenda today. And it's interesting because COVID has been such a disaster to our nation, but the silver lining of COVID is that we have leapt forward, you know, in leaps and bounds in the area of accessible telehealth for the citizens of the US and specifically Nevada. So when it comes to mental health, as you know, Mental Health America ranks us as 51st in the nation and has done so consistently for years, which is a sad embarrassment for the state of Nevada. But we now have this unique opportunity to pull ourselves out of the hole. And some of the beauty of telehealth is that it really meets all of the criteria of assisting patients at their home, in their environment, in the least restrictive method possible. I mean, if you think about all the stigma that's associated with getting mental health treatment, now you have this ability to do so in the privacy of your home. You don't have to drive to somebody's office, find transportation to get to somebody's office, wait in the office, wait afterwards. So there's a time savings, but in addition to that, there's the comfort savings. And I can tell you from the students that I teach, there's actually improved clinical outcomes. So both locally and nationally in discussions with other program directors, I can tell you that adherence to patient visits has been improved with the use of telehealth. Furthermore, in the child and adolescent arena, which is that in which I operate, kids and adolescents are used to technology. And the quality of the engagement that we've been having with our patients is vastly improved. Kids who wouldn't speak to you in the office can now walk around the room with their iPhone or their computers and show you their trophies or show you their pets, pull you into their lives in a way that really enriches your ability to provide improved clinical care. So I just leave that simple comment because I know you guys have time as a constraint, but I offer to come back and speak on behalf of any of my hats that I wear. Telehealth is an area in which I have practiced for many, many years. This is nothing new, but I'm now in a place where I'm training all of our residents and fellows in telehealth. We operate 100% in the telehealth arena, and it's been extremely successful. And I'm hoping that as a patient protection commission, looking out for the citizens of Nevada, we now have this tool in our hands that we can readily use and advocate for to help everybody get their needs met in the best way possible. So if you have any questions, certainly ask me. I know that technically we don't ask guest questions, but ask. And if not, I'd be happy to come back at any time. Thank you.
Thank you. Sarah?
I am actually going to now turn it over to Samantha Sturgis, if I might be saying that wrong. Samantha, it is your time.
Hi, my name is Samantha Sturgis, and I'm a dental hygienist in Southern Nevada. I'm here today in hopes that you'll be able to assist myself and the dental community to better serve and care for the oral and systemic health of the citizens in Nevada. I'm sure you're aware when COVID-19 hit Nevada, dental offices temporarily closed for 7 weeks and provided only emergency dental care for patients to mitigate the spread of COVID and to preserve much needed PPE that hospital staff would require during this pandemic. As we started to transition back into reopening the state, a phased action plan for guidance to dental service was developed by Governor Sisolak's Medical Advisory Team, Department of Health and Human Services, and approved by the Nevada State Dental Board on April 30th. This phased approach came initially with restrictions to practice in the first phase, which included restricting the use of ultrasonic piezo devices for dental hygiene procedures, any elective and aesthetic procedures, and certain orthodontic and periodontic procedures. As a dental hygienist, we were instructed to return to practice and treat patients with periodontal disease, but without the use of an ultrasonic or piezo device would not be providing the definitive and comprehensive care these patients require. For a healthy patient without any active periodontal disease, hand instrumentation alone could suffice. However, periodontitis is caused by a bacterial biofilm, and studies have shown in order to properly treat this disease, we must disrupt the bacterial cell wall, and use of an ultrasonic device is combined with hand scaling is appropriate and essential to treat this disease properly. At this time, we should have progressed into the next phase of this approach, but however, unfortunately, three of our board members have resigned over the period of this pandemic, and now our dental board is left without a quorum to handle any business and ultimately give any authority for dental providers to return to full scope of practice. For over 6 weeks now, many of my colleagues have been back to work trying their best to treat the patients in our community without proper tools and equipment. Additionally, many patients are being turned away because as healthcare providers, we know that we cannot possibly treat these diseases definitively without the use of the ultrasonics and piezos. Ultimately, this is increasing the risks and comorbidities such as lung disease, heart disease, diabetes, hypertension, Alzheimer's, obesity, pregnancy complications, and COVID-19. I have specifically heard of at least one patient that presented with advanced periodontal disease requiring extensive periodontal treatment, but was not able to receive definitive treatment at this time, and then died of a heart attack a week later. Could that heart attack have been prevented had this patient been able to receive the appropriate treatment anytime in the last 13 weeks? I can't definitively say that, but I can say it's highly possible, and it breaks my heart as a dental provider that this has happened and could continue to affect more patients every day. I have rallied along with my fellow dentists and hygienists, reaching out and pleading with Governor Sisolak to take immediate action and address the concerns hitting our dental community, but we remain at a standstill. I'm asking for your help, your voice in conveying the concerns of the dental community to Governor Sisolak. The dental community is asking that either he authorize dental providers to move forward into phase 2 of this approach or appoint the necessary dental board members and require an emergency board meeting to move us into phase 2 by the end of this month. Thank you for the opportunity to voice the concerns of the dental community in Nevada and taking the action to promote patient access to the highest quality of care.
Thank you for your testimony. Sarah?
Great, thanks. And it looks like we have Dan Musgrove. Dan, it's your time. Okay, I'm going to go to Laura Hall or Hale. Hold on one moment. Laura Hale.
Apparently Dan got disconnected. We just got a text from him.
Okay, let me just, we'll go to Laura.
Yes, I'm here now. Sorry, I got dumped out a couple of times. Good morning, Mr. Chairman and members of the commission. My name is Laura Hale, and I'm a member with Indivisible Northern Nevada. And I apologize if I'm repeating things that have already been said. I missed some of the input, but we are, of course, supporting wearing masks and messaging that to all of our members. But we have somewhat limited outreach. So we're just asking the commission to support requiring masks, people wearing masks, and maybe looking at working with businesses to do things like the casinos are doing, where they're handing out masks when people come in. We're noticing as we're out and about in the community that many people are not wearing masks, not social distancing, and we understand that in some states there have been threatening activities when people are required to wear masks. But we think that in Nevada, we can continue to try to work with those folks. So just again, asking this commission to do whatever you can do to work with the governor. We sent a letter to the governor and some of the local mayors last week asking to require that people wear masks, and to the extent that this commission can help to reinforce that, we would appreciate it. Thank you.
Thank you, Laura. Good to hear your voice. Glad to know you're not completely retired.
Thanks, John.
Sarah.
Okay, great. Dan, I've got you back on. Your time.
Thank you, Sarah. Hi, everyone. Dan Musgrove. Thank you for the opportunity to testify. Today, I'm here on behalf of two entities, really. I'm a member of the Clark County Regional Behavioral Health Policy Board. As you know, back in the 2017 session of the Nevada Legislature, AB 366 created these regional policy boards. And I apologize, just as Dr. Durrett was beginning her discussion of telehealth for mental health, I got cut off and thrown off. So I don't want to be repetitive, but I want you to let you know that we had a meeting on Friday, the Clark County Regional Behavioral Policy Board, and we are going to pursue our bill draft focusing on parity in telehealth. And so as Dr. Durrett started to talk about, we had testimony that we have had incredible access to mental health using telehealth during the pandemic. Numbers have actually gone up in usage and access to providers. And we just think that is, again, one of the benefits to all of this is showing how great telehealth can work. And so as you hear and listen today, discussions on telehealth, we want you to think about, because obviously you have the year of the governor, and our bill draft talking about parity in terms of payment wouldn't get heard until the 2021 session. And I think that we may have some opportunities for special sessions. We know that there's one been already called, that you as the PPC may have the opportunity to put forth some ideas to the governor and the legislature as to things that need to take place now. And I think that is something that ought to be considered, because we don't want folks to not have access to telehealth, whether we have a pandemic or not. And so as a board member of the Clark County Regional Health Policy Board, this is something very important to us. And so we wanted to make sure you were aware as well as you begin your deliberations today and hearing about telehealth. So thank you for the opportunity to testify.
Thank you. We'll be following the work of the boards pretty closely, to be honest with you. Sarah?
Okay, great. It looks like we don't have anybody else, so let's just give them a moment. If there's anyone else that is attending, or if you would like to speak during this set of public comments, please raise your hand. Okay, Mr. Chairman, I don't have anyone else who is indicating they'd want to speak. And then I would just ask that I turn it over to Ms. Mayville to read in any written testimony.
Hello, we have an email from Jenna Gomez, who is an RHD. She says, as an RHD, I do not wish to use the Cavitron at this time since COVID-19 cases have been on a significant increase, even more so than prior to all lockdowns. The use of Cavitrons or other aerosol producing instruments will likely spread the virus to not only the clinicians, but to other employees, and most important, to the patients. We are making do with hand scaling until COVID-19 has a vaccine or has flattened. I vote to continue not using the Cavitron. And then from Sandy Dupay Larson, who is also an RHD, she says, I'm a dental hygienist in Southern Nevada and have been so for the past 16 years. The Nevada State Board of Dental Examiners adopted the DHHS memo that outlined guidance dental services in a phased approach on April 30th. For a month now, myself and my colleagues have been back to work trying our best to treat the patients in our community without the professional armamentarium that is available to use to deliver the standard of care. As dental care providers, we have a professional standard and ethical duty to deliver the standard of care. Treatment is being postponed for many patients that require procedures that utilize equipment that create aerosols that aid in the removal of biofilm and deliver the lavage for an increased prognosis of treatment. Without the use of these devices, we are not able to treat their disease definitively and can possibly increase their health risks if they are already compromised. Published literature shows a dental high-speed handpiece can produce the same or more aerosols as an ultrasonic piezo. With the use of products utilized in the high volume suction, aerosols can be reduced by 90%. If used in conjunction with the filtration system, they can also be reduced more. COVID-19 has brought many challenges and high emotions to our profession, but with direction to aid in the management of these aerosols will help alleviate some of this unrest in the dental community. I understand there is an increase in numbers of cases and the concern is legitimate. But if we do our due diligence and look at dentistry's track record for transmission, we have done very well. We have managed SARS, MERS, hepatitis B, AIDS, and TB for years without incidents in reference to aerosolization. The next phase would be to restore our full function as dental providers and allow us the ability to provide and complete and absolute necessary dental care our patients require. I, along with my colleagues, plead that you aid in helping us restore our full scope of practice by moving us into the next phase for dental services. Thank you, and I'm looking forward to hearing from you. That's it.
Thank you. Mr. Chairman, that concludes public comment.
All right. I'd like to thank those who provided public comment at this meeting and just remind the public that there's an opportunity to submit comment before, during, and after each one of our meetings. And you can do that by email and, of course, a couple of vehicles for you to present in person, even though we're going virtual. I'm going to be pretty spare with my opening remarks. We have a full agenda, including updates from a variety of folks, including the provider community, but also our first set of testimony on the topic of telehealth. Looking forward to all of those. Before we do that, I would like to see if there is any comments with respect to our June 9 meeting minutes, and would like to have a motion to approve those.
This is Mason. I'll make a motion to approve.
Could I have a second?
Howard Barron, second.
Thank you, Howard. Any discussion? All right, all in favor, say aye.
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 Any opposed? All right, I believe those are approved. Thanks to both Sarah and Ms. Mayville for putting those together in a really timely fashion for me. I usually see those minutes a couple of days afterwards and just want to acknowledge they do a great job of that. Next up on our agenda is an update from Caleb Cage, who is the COVID-19 response director with respect to the Office of Disease Outbreak Management in the governor's office. Caleb, the microphone is yours. Thank you for joining us.
Thank you, Chair. First, let me just check to make sure audio is working. Okay, got a nod from everyone. I appreciate that. I'm going to keep my comments very brief and answer any questions you have out of respect for your schedule and make sure I'm addressing the things that you're most interested in today. As you all know, we have moved into phase 2 as of earlier this month in the governor's plan to reopen the state of Nevada under his Nevada United Roadmap to Recovery roadmap or plan that was put together and released earlier this year. What phase 2 means technically, as we all know from the directive that was released, was that vulnerable populations are encouraged to stay home as much as possible. that businesses throughout the state are encouraged to require their customers to wear face masks, that we've reached a 50% capacity for retail. And as of June 4th, gaming establishments in the state have reopened as well. With this dramatic change in our reopening, we are in a position where we have to rediscover the baseline with social distancing, with masks, with stay-at-home orders in phase 1. And prior to phase 1, our numbers were relatively low. I believe it can be argued that we successfully flattened the curve here in the state of Nevada. And with increased interaction between people, there will be increased infections and spreads. And as Director Whitley often says, I believe I saw him on here earlier, there will be outbreaks. We just have to make sure that we manage those outbreaks successfully and effectively. And as we continue to try to determine what the new baseline numbers are, we find ourselves in a position where, as of today, we have just over 280,000 people in the state of Nevada tested, with 13,535 confirmed cases and 489 deaths. And that, to put that into context, we've increased testing from last week to this week by about 40,000. The testing apparatus, whether it's collection at the local or tribal community level, or lab testing through the Nevada State Public Health Lab or the other lab partners in the state, is doing a considerable job. Again, 40,000 new tests approximately this last week were concluded. 330, there were 330 new positive cases as of today with no new deaths. This is important, this number 330, because it moves our 7-day moving average for test positivity to 9.2%, and our cumulative test positivity rate all the way back to the beginning of running these numbers to 5.6%. So we are seeing an uptick. We are seeing increased positivity, and we are continuing to take measures to A, monitor that, and B, mitigate that uptick. Monitoring is, like I said, an effort to determine what the baseline is, what the new baseline is, and to mitigate really comes into play with the Department of Health and Human Services contact tracing and the support that they're providing to local and tribal communities throughout the state. So, Mr. Chairman, happy to answer anything further, delve deeper, whatever you need. But I wanted to just kind of give a high-level overview for you and your commissioners here as you begin your meeting.
Thank you, Caleb. I actually did have a quick question. When you talk about an uptick in cases, I just was wondering if you're seeing anything at the local level or regionally that gives you concern.
Yeah, thank you. I would say that obviously the uptick and the increased infection rates and positivity rates are obviously things that we're monitoring very closely to determine that new baseline, as noted previously. I think that when we have data surrounding longer term data that we can identify trends and those sorts of things, the governor will continue to assess that to determine whether or not there are reasons for concern. As you know, the governor on Friday asked the medical advisory team, the MAT, to provide some recommendations regarding face coverings in the state, and I believe those recommendations are being reviewed currently as we speak. So yeah, we're monitoring it very closely. We're taking every effort to assess the data and determine what the best policy steps are going forward.
This is Dr. Khan. Quick question for Caleb on this consideration for the mask use. Do we have any timeline internally for final determination on the use or not use of masks?
Thank you, Dr. Khan. Caleb Cage for the record. We don't have an official timeline right now. I will say that the recommendations have been returned and they are under review right now. And I would say that it would be sooner rather than later if we had a determination on that.
Mr. Chair, it's
Yes.
Bobette Bond. Can I ask a question?
Yes, of course.
Caleb, thanks. I appreciate the updates. I am trying to understand where the Patient Protection Commission could help with that dialogue about protective wear, because our workforce ends up being patients too if they get sick. And I know the transmission rates inside the casinos are something that's under discussion, but I haven't heard the governor weigh in on the casino industry itself yet. So Mr. Chair, maybe there's a way for him to come back and report on what's going on with masks, because once there's more decisions about it, because I do think it's going to be an ongoing issue. I think certainly the Culinary Health Fund is worried about people getting sick because they're wearing masks at work, but the patrons are not. And some security at the hotels is doing a different, there's no consistency in the community right now about wearing masks at work. So there's that. The other thing I wanted to try to get in front of you is if we could talk about contact tracing in a future meeting. And I know you issued that report last time, which was really helpful to go through. It would be wonderful to know what exactly Nevada is doing and where the resources are coming from. And if there's anything that we could do innovatively to bring a faster contact tracing program into the community full time. Thank you.
Thank you. Caleb doesn't realize this, but we have him tentatively penciled in a number of future meetings. So we will be getting updates from him in the future, and I suspect contact tracing will be coming to a PPC agenda sometime soon. So I'll leave it.
Thank you.
Other questions for Caleb? All right. Thank you, sir.
Thank you.
Continuing on with our agenda and presentations, we have 3 presentations from the provider community, hospitals, and the Medical Association to be specific, as well as a presentation from Joan Hall and Nevada Rural Hospital Partners. So I believe Bill Welch and Chris Lake are up now.
Great. Thank you, Dr. Packham and commissioners, for giving me the opportunity to talk to you today. Can we bring up our presentation, Sarah? Great. Well, terrific. While the presentation is coming up, let me introduce myself. My name's Dr. Christopher Lake. I'm with Nevada Hospital Association. I'm the Executive Director of Community Resilience. And I'm here today to talk a little bit about the hospital story and our response to the COVID-19 pandemic, and present how we prepared and what we have going forward. There we go. If we could get to there, perfect. So I'm gonna speak to you just about 4 basic issues and try to keep it very high level and moving forward relatively quickly, because I know we lost a little bit of time. We're going to talk about Nevada hospital response, our challenges, our opportunities and lessons learned, and also some future concerns that we have going forward. Now, this is a story that started actually in late December, early January, as the hospitals in Nevada began to monitor what was going on with a novel coronavirus in Wuhan, China. Next slide, please. And as we started watching this virus migrate around the world and ultimately turn into a pandemic at some point as it spread, we began to work within the crisis standards of care that have been developed over multiple years in the state of Nevada. We also maintain a master mutual aid agreement between all of the hospitals throughout the state of Nevada, and that includes the short-term acute care, the critical access hospitals, the long-term acute care hospitals. Everybody is a signatory on this master mutual aid agreement that allows us to share resources such as PPE, pharmaceuticals, as well as staffing if we needed to. This was very instrumental in the beginning when PPE started to become a shortage at a few local hospitals and not at others. We also, the hospitals responded by voluntarily changing visitation policies, surgery policies, canceling elective surgeries, and essentially changed the entire model for healthcare in Nevada to make sure that we had the excess capacity and had the resources available should we see a major surge. As far as data reporting, we heard from Caleb about the data and monitoring and watching what is going on. The hospitals began submitting data 7 days a week. Every single hospital, including in all those categories, submitted data on their occupancy rates, the use of ventilators, the number of COVID patients, healthcare employee illness, as well as the levels of PPE and the critical equipment that they had available as this pandemic started to move around the continent. Next slide. Some of the challenges that hospitals faced in the beginning was with data collection. Everybody wanted data on, and different data elements too, I might add. And it was from multiple focal points. We had county health officers that wanted data. We had coalitions that wanted different data. We had FEMA, Health and Human Services, the White House. Everybody was trying to collect different data points and from all the hospitals simultaneously. That was a huge challenge that we had early on. Along those lines, PPE was also a huge challenge simultaneously. The supply chain was dysfunctional at best. Most of the PPE in the world was actually made in Wuhan. So as Wuhan had their coronavirus outbreak locked down, many of those factories were also closed and unable to produce the necessary PPE, creating a huge supply side shortage. The increased demand around the world created double-digit price increases. So there was a point in time when a single N95 mask that would normally be about 35 cents was selling for in excess of $8 a piece, which created huge financial burdens for all the hospitals. And then there were quality control issues on some of this PPE as companies all around the world kind of scrambled to make counterfeit PPE and try and fill that supply chain void and sell it to our hospitals, which wasn't really obviously helpful along those lines for our personnel. Next slide, please. Workforce challenges early on, and also as we peaked here in early April, became apparent as well. We did have some fear of catching coronavirus among our workforce, which basically resulted in some personnel calling off, and we did see some illness as well within the workforce. Whether that was occupationally acquired or community acquired is unable to tell, but it correlated with most of the community spikes that we saw. There were also some significant pay increases in the Northeast, particularly in New York, that lured some of our workforce away. Lab testing was a problem and continued to be a problem throughout much of the COVID-19 pandemic here in Nevada. In-house capabilities of the hospitals were troubled because the CDC wouldn't originally release the ability for hospitals to do the testing in-house. It had to be done at a public health lab. This resulted in hospitals trying to test their patients that were suspected of having COVID, but unable to get results back for 4 to 6 days. Early on, that was even longer due to some supply issues, not having the swabs or the transport media to get the sample actually to the public health lab. The other issue that was very debilitating was the hospital workforce was not prioritized as far as new hires and exposures to COVID, which meant at the same time we were having those workforce issues, we had employees that then needed to be quarantined and were taken out of the ability to provide patient care for upwards of 14 days until we could get these test results back. Next slide, please. So we did recognize and observe some opportunities and some lessons learned as we moved through this. The first one that I would like to point out is currently in Nevada, we have 4 coalitions throughout the state of Nevada. These are preparedness coalitions, and a single statewide coalition we feel would benefit all. Particularly when we started with the data collection, and every coalition had a different approach to that, and managing PPE and scarce resources. A single statewide coalition was a lesson learned and is an opportunity for the state going forward. The data collection that the association provided has proven invaluable to the governor and to all of the emergency managers throughout the state. By having a single point of entry, if you will, for the data, everybody was looking at the same data. Everybody had the same data points. It was collected in the same ways, and we could compare regional approaches and hospital by hospital approaches as well. The crisis standards of care, that was pre-planned over multiple years. It had never been instituted before this. Prior to the pandemic, and we found that it really did provide a good framework for the state and gave us an ability to attack this pandemic with a running start instead of having to build up from the ground up. And knowing the key players for communication definitely lessened the confusion. We were lucky in the fact that we are a relatively small state, and most of the people have worked together on other major issues and initiatives. Next slide, please. We do have some concerns going forward. There is a concern that if the president declares the emergency over, that waivers such as 1135 and 1115 waivers that deal with Medicare and Medicaid and how hospitals function and different things, very technical issues, would go away overnight. These waivers require a presidential declaration of a public health emergency, as well as the Secretary of Health and Human Services. So if the president were to unilaterally declare coronavirus emergency over, those waivers would simply go away overnight. We are also concerned about the presence of COVID-19 during normal flu season. The flu generally impacts our hospital occupancy and our capabilities with ventilator utilization and intensive care utilization just in the normal course of flu season. So if we were to see a significant COVID spike simultaneously with a bad flu year, that could be a situation where we may have to scramble and go back to those crisis standards of care. Testing availability and result turnaround time, again, is a huge concern. We really, as we enter the flu season, need to shoot for having that COVID-19 test back to the hospitals within 24 hours. We're not there yet, but we really need to strive to get there. And then ongoing PPE supplies continue to be an issue. The industry and the supply chain is stabilizing quite a bit, but should we see a rapid increase in COVID-19 simultaneously with that flu season, it could very easily go back to a situation where there are not enough PPE supplies to meet the demand and the need at our hospitals. Next slide, please. At this point, I'm going to turn it over to the president and CEO of the Hospital Association, Mr. Bill Lowe.
Bill, you got to unmute yourself.
Can you hear us? Thank you. We had a text message that indicated that there might have been some audio problem on our side. I hope that was not the case and that you all got to hear Mr. Lake's presentation. Before I start, I wanted to speak a little bit about going forward, but I do want to make a couple of acknowledgements. I really want to thank the governor in his leadership. It was his leadership that helped us be able to flatten the curve and manage the COVID-19 situation, unlike what happened around other parts of the country. His continued efforts to take measured steps on how we respond to the COVID-19 continues to allow us to be in the best position to respond to COVID-19 patients in the pandemic. So we really want to acknowledge the governor and his team for their efforts and their leadership. Also want to thank all of the various public health agencies, EMS services, and all the other partners. It was all of them coming together that allowed us to be as effective as we've been able to as a community to respond to the COVID-19. With that, a couple of things that I wanted to share with the group. As we go forward, Chris talked about a number of our experiences on how we responded. He talked to some of the challenges, some of the opportunities. The governor, I understand, wrote a letter to the PPC Commission on May 19th, and I just wanted to touch lightly on the 5 points he addressed in there in an effort to demonstrate that we hope that the hospital community will continue to be allowed to come and partner with you, the commission, and others on the development, the strategies on how we can put ourselves in the best position to respond. For example, the first bullet, accessing of healthcare for the vulnerable population. Nevada hospitals are the largest provider of the Medicaid population, the uninsured population, and the underinsured population. And we are not the public health delivery system, but we've become a very essential part of the public health system as a result of that. And certainly would like to be at the table as we discuss how we can continue to ensure access to the care of this population and hopefully expand access so that we have a full wraparound capability so folks are not just having to come to the hospital ER for primary care. Innovative approaches to providing health care, the second bullet in his letter. As you'll learn a little bit later, the hospital community was essential in expanding the broadband capabilities throughout the state, at least for the hospital community, on being able to facilitate telemedicine throughout the state of Nevada, again, through our hospitals. The other thing is that hospitals were some of the first to be engaged in telehealth in the state of Nevada, going back some 30 to 40 years ago with teleradiology, and has evolved to include many other clinical functions through the hospitals, as well as in partnership with our physicians in the community. So we think that we have a lot to bring to the table on how telehealth can be expanded and improved. Finally, we were part of a task force that worked on the telehealth laws in this state, AB 292, which I believe was passed in 2015, and really opened up the window of opportunity for expanding telehealth in this state. In effect, the Medicaid waivers that just went into effect recently, for the most part, the waivers really brought Medicare and the programs it regulates to the same level of flexibility that we have in Nevada for our commercial health insurance in Medicaid. There was a couple of components that it did expand that helped even those areas, but we have done a lot with telehealth law in this state. We think that we can provide some assistance in that arena. As it relates to public health, which is the third point, in gathering of information, just want to point out, Chris talked about our centralized system that we now have and got it embedded into our hospitals, and we have the infrastructure here at the association that we're going to be on an ongoing basis continuing to collect the data that we are sharing with our partners right now as we manage through the pandemic situation. But there are other data components that we are instrumental in providing to the state. For example, the cancer registry, the trauma registry, the stroke registry, the newborn registry, and there are several others, but that gives you a sense of the amount of data that we're collecting and that we're pushing out to the state. So we think that we are an important part of evaluating where we are with public health and some of the challenges that we have with health-related issues that through our data can assist the state in developing strategies on how to respond. Next slide, Sarah. Excuse me, next slide. Improved data collection and analysis, evidence base. As Chris indicated, we spent a lot of time building the infrastructure for collecting for emergency response. We have always done that to some degree, but we learned through the pandemic situation that we needed to expand that, and we've invested a significant amount of resources and staff time and expense in making sure that we have a quality system in place. And I think that it's there to help you, help this governor and our other partners as we not only manage the pandemic situation, but as other situations arise. We think that we can be very helpful there. Finally, as it relates to the healthcare workforce, as we think about healthcare workforce, certainly we're not the only partner in that arena, but much of the training of your healthcare workforce happens in the hospital, particularly as it relates to your physician residency training programs, your nursing clinical rotations, and other allied healthcare professionals. We also are one of the largest healthcare employers in the state of Nevada, and healthcare workforce is essential to our ability to respond to the community medical needs. So that we hope that as you look at healthcare workforce, we'll be able to work with you and others on the best approaches at addressing healthcare workforce needs. With that, I'd like to again thank Dr. Packham and the PPC Commission for allowing us to speak to you today. And we both would be happy to try to answer any questions that you might have.
Yeah, I'd like to open it up to questions as we go from one group of speakers to the next, since I think you might have some specific questions for Bill or Chris. Any questions from the commissioners?
Mr. Chair, this is Mason. I'd like to ask a question.
Sure. Welcome. Go ahead.
Hi, good afternoon, Bill and Chris. I do want to just kind of highlight one of the things that I'm a little concerned about. And Chris, you had mentioned it, as we approach the flu season, I think there's an opportunity to this commission to really promote vaccinations as far as immunizations as far as the flu, because it is a bit concerning as we continue to go through our phases and we hit October, November, and we have a bad flu season on top of COVID that will still be in our community during that time. I think it will be of much concern for our state and our resources. So I think there's an opportunity for us to help promote flu shots and try to promote that, because we, quite honestly, from the time frame of when COVID entered our state, we were coming on the tail end of the flu. So we got a little bit of a reprieve in the healthcare industry, but I think we need to be very concerned about that as we approach the fall and when we start to see the results of respiratory illness hit our community. So, but I appreciate you talking about that, Chris.
Mr. Chair, I have a question. It's Bobette Bond.
Go ahead, Bobette.
Hi, Bill. Thanks for the presentation. I'm wondering, I just read about this and I had never talked to you about it, so this might be a conversation for the future, but why was the data collection that you all did not something that was made public? I remember people wanting to see, cases in each hospital, and there was conversations about that wasn't going to be released. And I think I'm just, with this transparency hat that I seem to always wear, patients and consumers in the community needs to know that information about what's going on in the hospital. So can you help me understand that part?
Thank you, Bobette, for the question. Again, Bill Welch with the Nevada Hospital Association. Initially, it was a challenge to get all of the information coming in a consistent and standard basis. So we were very reluctant to be releasing data until we were absolutely confident in the data, and we also knew that we were collecting it from all of our hospital membership. Not only our hospital membership, but other hospitals licensed in the state of Nevada. That took us 4 to 6 weeks to ramp up to have the absolute confidence. We were fairly confident with the majority of our short-term acute care hospitals, but we were being asked to collect the data across all hospitals in the state of Nevada. Once we got to the point that we were feeling the data was consistent and we could substantiate it with any questions, we began to post it on our website. And so I think you will find that since mid-April, we have been posting, or early May, we've been posting the data. Now, we do not post it by individual hospitals to the point that you asked, Bobette. And the reason that we did not post it by individual hospitals, we didn't want patients being steered one way or the other for what they may not completely understand as the data was being reported. So while the governor's office had received all of that information to help him best manage what was going on, we felt it was in the public's best interest that while they understood what was happening, how the hospitals were responding, we felt it was best to keep it in a consolidated manner.
Yeah, this is Dr. Khan, a question for Bill. Bill, regarding the emergency room visits, I know the visits were down by 30, 35, 40%, depending on the hospital during this whole situation. A lot of sicker people just didn't come to the ED. And are the hospitals noticing any improvement or increase rather in the ED visits? And how does the preparation board vis-a-vis upcoming flu season and these sicker patients who avoided going to the emergency room also trying to get into at that time?
Thank you, Dr. Khan, for the question. Bill Welch for the record. This partially goes into the question that Bobette asked a minute ago. That was another one of the reasons that we were reluctant to try to identify individual hospitals, because we wanted patients to feel comfortable to access their hospital in an emergency medical condition. You're right, our utilization dropped in excess of 30%, and it wasn't because people did not continue to have medical emergencies that they needed care, is that they were uncomfortable to come to the hospitals because they were afraid of being exposed to COVID-19. As we've gotten the curve flattened, and our spike was not that significant. We had that a spike in mid-April through the latter part of April, but it was a minimal spike. And since we've had the curve flattened, we've actually initiated a campaign with the hospitals and others partners in the community to again begin promoting that it was safe to come to the hospital if you had a medical emergency. We've talked with EMS. We know that their runs dropped dramatically as well. Patients who were having cardiac issues or other medical conditions were, again, afraid to come to the hospital. We're starting to see a slight increase in our utilization, but it still has not increased back to the level that it was pre-COVID-19. We are beginning to see some of those patients. When we talk about elective medical procedures, I want to make clear that what we're talking about are medically necessary procedures. They're just not life-threatening at that particular moment. We are now beginning to see an uptick in those patients coming in, whether it's for cardiology, oncology, gynecology, et cetera. We are starting to see an uptick in patients coming back to the hospital for that. But again, still not back to the normal volume that we've seen in the past. We measure our beds in 3 ways, and there's been some confusion about that in the state as hospital bed data has been reported. To your point about preparation for an upcoming flu season, we measure our beds and our data is being reported to all of our partners based upon our staff capacity, meaning that we're looking at what our average daily census has and is trending, and then we make sure that we have staff available for that level of utilization, as well as additional staff that we can call in as necessary. So we have our first level of beds that we are evaluating. That's staff capacity. Then we have licensed capacity, which is the actual total number of hospitals beds that are licensed by each of the various facilities throughout the state. And then we have surge capacity. And the crisis standard of care would call for the hospitals to expand their capacity up to a minimum of 10%. As we've measured what has happened through the pandemic situation, we've been managing somewhere in the mid 70% of our staff capacity. So I want to emphasize our staff capacity, which is the lower bed count. So we feel reasonable that we should have beds if we get hit both with the flu and the COVID-19 continues on. Will it be a challenge for us? Without question, because we will have to make sure that we have the PPE supplies, and then equally as important to the PPE supplies is making sure that we have the workforce. And I would say the workforce is probably going to be as big of any challenge that we will have in trying to make sure that we're prepared to respond to a normal flu season and a continued COVID-19 if in fact that continues. I hope that answers the question.
Yes, thank you.
Chairman Packin, I have a question. This is Teresa Bohannon for the record.
Go ahead.
I have a number of questions actually. One related to workforce. Do you keep any statistics on how many hospital workers are contractual, like a travel nurse? And if we were to get hit again hard, if that would limit our capacity to provide the type of care that patients deserve. I'm also curious how prepared our rural hospitals are. While we've been fortunate in the state to not see a significant number of cases in the rural communities, that doesn't mean an outbreak couldn't happen as communities reopen and there isn't the social distancing that's happening sometimes in our rural communities. So I'm curious if you can answer those questions. And then my last question is, when you did some of the lessons learned, you had mentioned that we were able to meet the needs, but I'm wondering if there was any type of surveys deployed to the patients that were in the hospitals, and if you got any feedback from them, any anecdotes about what their experience was like. Thank you.
Thank you. This is Bill Welch. I'll try to do my best to remember all of your questions and respond to them. We do track our nursing staff by employed staff versus registry staff. So we do have that information. Our hospitals did become somewhat dependent upon having registry staff to supplement our full regular staff. One of the challenges that we ran into is over 26 states in the nation have a nursing compact, which allows nurses to move between states without having to get licensed in each state. And we saw that being a challenge with nurses leaving our state. And Nevada is not part of the nursing compact. The governor did several weeks into the pandemic situation as part of one of his proclamations did waive the individual licensing requirements in Nevada, basically making us a member of the compact or providing for reciprocity, and that helped us in bringing in staff into the state. All of our hospitals do have contracts with registry companies. And as part of those contracts, I'm not involved with their individual contracts. Possibly Mason and Tony, who are hospital representatives on your commission, could speak more specifically to their contractual relationships. But I do know that they are required to have so much resources available to respond if they call on them for additional staff, whether it's nursing or other medical professionals. With regards to the rural community, I think Joan Hall is going to be the best person to respond to that. She's the President and Executive Director of the Nevada Rural Hospital Partners. All those hospitals are part of the Hospital Association, and we work very closely with them. They didn't have a lot of challenges. Fortunately, they did not see much COVID-19 in their rural communities, but Joan would be the best to speak to that. With regards to patient surveys, I believe we did not do through the Nevada Hospital Association. It's a great question, and we will take that in-house and discuss it, and I'll discuss it with my board of directors. I do believe that the hospitals all do perform patient surveys as part of their CMS requirements. And so I'd have to look to the hospitals as it relates to patient surveys. But I can tell you that through the Hospital Association, we did not collect that. We were more focused on making sure that we had the resources and the bed capacity, et cetera, to be able to meet a influx of patients.
Yeah, looks like Tony has a comment.
Thank you, Chair Packham, and thanks, Bill and Chris. Appreciate your presentation today. You know, it strikes me as we're having the conversation as a commission, given the agenda that we had last month around the public, a little bit of the public health response, and what we're seeing this month on the agenda from a kind of the private response and how those two are coordinated. It seems as though there's an opportunity for a debrief, a root cause analysis, a look back to understand what went well from a coordination perspective and what didn't. So many people worked so hard, but in every crisis opportunity, there's an opportunity to learn from what we did, and we know that we're not out of this. And so I'm wondering about the role of the commission in being able to help us understand exactly where we can figure out what the coordination needs to be between the private and public sectors. For example, we know, and Commissioner Bond actually highlighted, the Hospital Association took up the responsibility of data and managing the data component of this. We know that the crisis standards of care have been in process for many years. We don't have still the authorized from the state the crisis standards of care if we were to go into a crisis or a surge in the next few weeks. Testing, we know that it was a difficult time for us around testing, and hospitals have had to invest in that infrastructure to make sure that we had what was available to serve the needs of our community. PPE, you heard that as well. I think one of the most important things for me, which needs a regulatory component, I just, while we were here, got an email on more protective equipment, and those come in 10 times a day, as do opportunities for testing. Every new vendor, and this is effectively practicing medicine without a license in our state, is offering test kits to people on the front line without having appropriate physician oversight for what to do with the results of those kits. People can just buy them on the free market and use them to the degree that they want. I think we need better communication and coordination between the public and private sectors, and there's an opportunity to do it before the next surge in the fall.
Bill or Chris, I don't know if
I have a question too, Dr. Packham.
Yeah, welcome.
This is Yarleni for the record. So this is for Bill. I understand that one of the main challenges was PPE supplies, and how it was dysfunctional the way it was distributed. So my question is, how was the PPE distributed? How did you guys organize the distribution, and why it was dysfunctional? And it was different for each hospital. Some hospitals had, I couldn't say a surplus of PPE, but definitely a lot more than others. And since this is a future concern also, what do you suggest that we do in order to fix the issue for the future?
Thank you for the question. And I think Dr. Lake would probably be better at responding to that. So I'm going to turn it over to him, but I need to turn my volume down so we don't get back feed.
Great, thank you, Bill. Well, with the PPE, there's several ways in which PPE was distributed. At the hospital level, the primary source of PPE was the hospitals themselves purchasing their own PPE for distribution the way that they normally do every day of the year. There was supplemental PPE that was brought into the state and through the Strategic National Stockpile, which is a federal resource. It's from Health and Human Services that then FEMA would take possession of and bring down into to two warehouses, one in the north, one in the south, and the National Guard would distribute that. We collected the information based on what the current levels of PPE were at each individual hospital, but it was the National Guard and FEMA, as well as people from the governor's task force, that divided up that very limited. They didn't get significant quantities. It was divided between all of the states and large cities. So, and generally based on a combination of population and the number of COVID patients that population was experiencing. So a lot of times we did not get as much PPE as would have been desirable, but that was basically distributed through a formula from Department of Emergency Management and the National Guard. We did not have a hand in deciding who got what or how much. We did try to advocate for the hospitals and for various community members, as well as EMS and even nursing homes and laboratory. When they got to very low or critical levels, we would advocate on their behalf and contact DEM and contact the National Guard directly and let them know if there was a situation that was dire, trying to keep the velocity of that PPE moving throughout the system so everyone could stay protected. I hope I answered your question.
Yes, and what would you suggest could be a way for us to fix the issue in the future, since this is a future concern for everyone, especially with the flu season coming?
Right. So a lot of the hospitals are trying to stockpile PPE at this point. They're buying as much as they can to get ready for the flu. I know that some larger systems are also investing in actually the manufacturing side of various personal protective equipment so that they can have a little bit of control in that. Now the problem, that is one of the solutions. Now, one of the problems that we're still experiencing is that this is a national problem. So every hospital in the nation essentially is trying that same strategy, which has caused the manufacturers and the distributors to create what they call an allocation system, where they are only allowing hospitals to buy as much PPE as they did in the average month prior to COVID. So it creates some challenges on its own, particularly for, we heard the dental community, we heard the nursing home community. Those are organizations that generally didn't buy a lot of this type of PPE prior to COVID. So they don't have an allocation from the manufacturer, the distributor. So as we try to build stockpiles for the hospitals, it creates some new challenges for other portions of the healthcare sector, if you will.
Thank you.
Thank you.
Any other questions? All right, seeing none, I'd like to move on to Dr. Swanger from the Nevada State Medical Association, and also believe Jaron Hildebrand is available if there's any questions. But Dr. Swanger, please take it away.
Hi, thank you, Dr. Packham and commissioners for inviting me to the meeting today. I just want to present to you on behalf of the Nevada State Medical Association our kind of experience with COVID-19. Our association is comprised largely of private practice physicians. I'd say about half of us are family practitioners, the other half are specialists. Our society is composed of MDs and DOs as well as a few PAs. We had sent out a survey about 2 weeks ago. Excuse me, probably about a month ago. The data has been collected and analyzed about 2 weeks ago. And we also reached out to the AMA to get some analysis from them and hear what's going on across the country to see if we were much different. And it appears that our data is pretty much in line with what we're seeing across most of the country. And some of that information then is that there's very high levels of concern about people obtaining adequate revenue for their practices. About 3/4 of physicians are very concerned. 1 in 5 practices have seen a decline in revenue between 1/4 and 1/2 of revenue, and about 1/3 between 1/2 and 3/4 of their revenue have seen declines. They think that most physicians feel that they can sustain their practices for about another 2 to 6 months at this level. About 1/3 of them aren't quite sure how long they're going to be able to hold out. Because of COVID-19 and the revenue loss, about 10% of practices have had to deal with layoffs, 15% have done pay cuts, 20% done temporary furloughs, and 30% have staff hour reductions. About 3/4 of our physicians have applied for federal assistance. About 90% have received federal assistance funding. As was mentioned previously, we've seen at the hospital and the ERs, we've also had a significant drop in patient visits. We have not had a return to pre-COVID levels at all. Prior to COVID-19, about 60% of our doctors were seeing like 45 patients or so in their practice per week per person. And about 82% of people were doing telehealth at that time. Now, we only have about 40% of our physicians are going to see that number of patients, the pre-COVID levels. So 60% are still, suffering as our practice is. And now about 43% of our physicians are seeing patients by telehealth as well as in person. So we've seen a dramatic increase in telehealth, unsurprisingly. But because of that, we've had some concerns we've seen develop out of physicians and our healthcare providers, which focus on technology, as we've had in this meeting ourselves. To make sure there's so many different platforms out there for our physicians. NSMA did align with 2 different platforms to give our providers an opportunity to seek out some technology. But there are so many different options out there for providers as well as patients to become comfortable with. So the hardware and the connectivity is a big concern, as well as obviously reimbursement and billing, tying it to revenue. We've been talking with the NHA and are concerned about parity with telehealth payments. Finally, as was kind of mentioned, there's a confidence of obtaining PPE is relatively low. So everybody's really concerned about making sure we can keep an adequate supply of PPE, as well as we talked about the in alignment with the healthcare needing PPE is having the healthcare workforce. There's a stress of having staff get the infection as well as providers. I myself in a group where we have few radiologists and we depend upon every person to be there if one of us falls out sick. We really don't have a backup plan. It's going to be very difficult to provide the care to the community that we'll need should one of us fall ill, as a lot of practices will have to. And that's about all I had to present. Is there any questions I can take, please? Thank you for the time.
Yeah, this is Dr. Khan. I have a quick question. You brought up telemedicine. I know CMS has already stated that the reimbursement would be equivalent almost to like a regular visit, give or take. The private payers, what are you hearing from your physicians about private payers reimbursing physicians lower than usual for telemedicine or like a phone call consultation instead of regular telemedicine reimbursement?
Yes, thank you, Dr. Khan. That is what we were hearing, and that is our big concern, is we want to make sure that from these payers that we will receive a parity. Otherwise, there could be a push
towards some of that. And we do have concern for the patient receiving the best health care possible. Sometimes telehealth can be the best, particularly for our rural communities. But in a more urban setting, for payers maybe to push towards telehealth with a less of a payment, as you suggest, then we could see a steerage we're concerned about, of steerage toward maybe suboptimal healthcare, where a patient isn't given the opportunity to see their health provider in person with a good physical examination. Should a lower payment model be preferred and steered in that direction? So that's our biggest concern right now, I think, is towards seeing that. We are concerned about that. That's a real factor out there, that we are going to see some of the big insurance carriers offer a discount basically almost for telehealth instead of a parity model.
Are you collecting data on that from your physicians to be objective information?
We haven't collected anything yet. We haven't heard anything, but that's a good idea. And Jaron, if you're on the phone, that's something that we should talk about doing, I guess, is some data collection at this point, if there's anything out there to be gotten from our members.
Yes, absolutely. We have done many of surveys, and the biggest concerns with our telehealth is the coverage parity, which we do have in the bill from the 2015, establishing payment parity, and allowing in-network physicians who provide care in person to also provide via telehealth. We also, patient and physician relationships should be able to establish for the first time and once parameters are met. And then licensure with state-based licensure for telehealth, and also just expanding acceptable modalities during these types of crises, as well as, when we go back to our day-to-day pre-COVID.
I see a question from Bobette.
Oh, you must just be looking at my face. I didn't flag one, but I have one, so thank you.
I can just tell, Bobette.
You're getting very good at this, Mr. Chair. My question is, I think this issue is, it's hard for us to get patients in front of us to talk about what their experience is. And I know Sarah's actually flagged that, and I know other groups have asked for more patients that have experienced telehealth. So I'm wondering if we can try to work on that so we can hear from them. But I do think there's going to be an ongoing debate between the providers and the payers on this, because in fact, from the payer's perspective, the visit should cost less, because making it more affordable lets us expand healthcare to more people. And it doesn't cost as much for the provider to provide the same service in a telehealth visit as it does for them to be in the office, making an appointment, using administrative staff, having a chance to spend more time with the patient. So I think there's got to be a balance here that we figure out. Very few states have mandated parity, so I think it's a long conversation about this issue before we move something forward. I just wanted to put that more complete dialogue on the table. Thank you, Chair.
Thank you. Additional comments? I see Tony.
Thank you, Mr. Chair. Ron, thank you so much for joining this morning. I was wondering if you had any comments about that point of how many new businesses are coming into the state and offering testing for a profit motive, but essentially distracting from the physician-patient relationship, right, which is so important in determining what test gets done. And to the point Bobette just made, I think what you pay for is not only the process of telemedicine, but the thinking that goes on in the doctor's brain about how to apply testing appropriately or inappropriately and do appropriate follow-up. All of that goes into the parity conversation. But Ron, any thoughts on how the doctor is getting distracted during the course of this business approach to testing for COVID?
Thanks, Tony. I appreciate it. And thanks for the invitation. We have seen quite a bit of confusion, I would say, particularly with the different types of testing. There's so many different options out there that it's been a lot of confusion, and even obtaining good information about COVID itself has been one of the stressors of some of our physicians, is to know what is reliable information. with so many different testing options out there, and as you said, the availability for patients to kind of almost go out and get this test themselves, it's been making it, it's been interfering with the patient-physician relationship, because there's more information out there, I think, than our doctors are able to analyze maybe and provide a good feedback to the patients when they're going out and soliciting their own information or relying on the internet for a lot of information that may not be vetted and accurate. So we have seen, I would say, somewhat of a breakdown as far as some of that relationship goes when you have these vendors out there just being able to push any type of product. The telehealth component of that is trying to, work on having a relationship with the patient. I think has been helpful to have that there, but it's not been the same experience as the in-person one-on-one time in the office. Not sure if I was able to answer that question appropriately. I hope I gave that a good enough answer for you.
I think Bobette has a follow-up.
I do. Thank you, Mr. Chair. I think you're raising a really important piece there. And I think if we had some patients talking, where we've seen this happening, we run a health center that shut down over this and went completely virtual. So we have about 500 patients being tracked by their docs online. And it's working pretty well, but I think one of the things that's a real issue, and it does differentiate between being in the office and these telehealth programs, is whether the patient can continue to see the same person every time that they try to have a telehealth visit and be able to continue that relationship with their doctor, which I think telehealth some of the models really disrupt that. And the patient's kind of stuck starting over or not having that relationship, So I think the mental health stuff we heard today about telehealth was interesting. I think what you're saying is very interesting, but I wonder what the experience has been from the doctor side if they're not seeing the same patients all the time.
Yeah, I wish I had an insight into that. I don't know if Howard, if you have some insight on any of that or any of the other physicians on the line.
Yeah, actually, thanks, Ron. This is Howard Barron for the record. I had a comment. We implemented telehealth fairly swiftly and adeptly in our very small private subspecialty practice in March, and had pretty good experience with it. None of our docs crossed over to see other doctors' patients, but again, we're a subspecialty. I wanted to comment on something that Bobette mentioned earlier, which was that maybe there shouldn't be parity in telehealth reimbursement because, after all, it's less expensive to provide that service. And I would say that's not true across the board. Speaking from my private practice, we had to come up with a flow diagram in order to process patients that were going to be seen via telehealth that use as many, if not even actually one more staff person's time in our practice compared to when people come in and check in person. And so other than possibly PPE supplies or paper products that are used in the office, I would say that from a personnel and time standpoint, the cost savings is zero for our practice. And I can just, again, I can't speak for everybody. I think that there's probably some cost savings in mental health, but as soon as you have to start processing patients, processing co-pays by phone, setting up patients, getting pre-histories on medication lists, advising the patients where they have to be and that they have to have their medications in front of them, and that in my case there has to be a legal guardian or parent available, and that they have to have appropriate equipment and IT support in order to be able to receive the chat and dial in. All of those things take time and personnel time, and we have not found it to be less expensive in terms of providing that care.
I have a question based on the presentation. This is Teresa Bohannon for the record. You had mentioned the statistic about from your survey that some physicians or practitioners have 2 to 6 months left before they would have to close their practices. Can you remind the commission again what that percent was? That seems staggering.
Sure. Yeah, thank you very much. You know what? It didn't have a percentage. It just said a majority of physicians can sustain their practices for 2 to 6 months at this level. There was no percentage given, just greater than 50%. Majority is
Greater
all.
than, right. So given, this is just a comment, given that we already have a shortage of medical professionals in the state, that seems stunning. I just want to kind of take a pause and a step back to say, if we were to say lose 50% of our physicians in the next 2 to 6 months, what would healthcare look like in the state of Nevada?
Yeah, that's the very scary thing. I know myself and our NSMA, we wrote a letter, on behalf of our members as far as sending to the PPP to refund that, because a lot of our practices were honestly about to close doors. I had received several letters from my colleagues saying that they were eliminating half of their staff and they didn't think they were going to be able to go on another month. Luckily, the PPP came through for them and they're still open today, but I know that their volumes are just like ours, down about 30 to 40%. And it's hard to, I think, cover your overhead and turn any profit at all. I know we're not turning profit right now. We're just trying to keep the doors open and our employees working. So, yeah, it's a big concern.
This is Dr. Khan. Following up on the same question, I'm seriously concerned about it. As was mentioned, there is already shortage of primary care providers for sure in the state as a whole. And even 5% or 10% drop out from providing that primary care, we would end up in a crisis. It's bad enough to begin with. I do know that those physicians, some of them I know personally, who were in private practice, to your point, are ready to close because the cost actually went up with the PPEs and all the protection gear for the few that trickled into their office, not even telemedicine. So to Howard's point, their cost went up, those who were in their private practices. The employers, the bigger employers who employed physicians have actually laid off some physicians from their companies, from provider services. And these physicians cannot go and open shop next door because it's fiscally not possible to do that either. So we are running, I'm convinced in my mind, if this continues the way it is, we're running into shortage of physicians, bad as it is already.
Mr. Chair.
I have a question, if you can hear me. This is Flo Khan. What can we do to help as a commission? What would be a recommendation that we could do to get patients to feel comfortable to come back into the offices, to go back to their regular course of treatment, or just to get back into general, their care schedule? Is there anything specific in terms of education that we could do to help with that?
I appreciate that. I know that's been a big effort and we've been working, I know NHA has been pushing that too, as far as putting out some PSAs, letting patients know that it's safe to come into the hospital or the office and not to let go any chronic conditions. I think I even saw a headline this last week that said there was gonna be about 10,000 more cancer deaths this year because of the delayment in screening exams. I think the message is out there. It's a matter of people feeling comfortable. One of the other things I heard that could be concerning as far as revenue goes for our practices is because of this took earlier. I'm a radiologist. I don't know if I shared that. I'm sorry. So I've been doing telemedicine for a long time, but a lot of our physician practices really count on kind of the fourth quarter when a lot of people have met their deductibles for their insurance payments. So we see a lot of drive-in procedures, particularly for imaging or more expensive care. And so fourth quarter, we tend to be quite a bit busier and usually do a decent job of making a profit and having revenue. our concern this year is that we've been hearing is that a lot of people, since they haven't been seeking medical care, a lot of people maybe have not reaching their high deductible payments. And so we may not see that fourth quarter push that we're used to seeing. And that's yet to learn from. I think messaging the community and having everybody realize that, we're now in phase 2 and it's feeling more comfortable to go out. We're seeing somewhat of a patient comeback, but it's not strong enough. And I'm not sure what else we can do, to be honest with you. I appreciate the effort. I think the messaging is out there and we continue to push the message that you need to seek your care, particularly for chronic health.
Along with Flo's comments, I was wondering, so we're talking about a whole portion of patients that actually know how to access care. Can we get data on or are there any results on the patients that don't even know how to access care? I think about the Medicaid expansion population, and I don't even know if people really understand about, using your primary care physician to even get a referral to your specialty care, et cetera. So I just wonder if we could get data on that and then maybe see if we could direct PSAs to that general population.
Yeah, that'd be something that we might be able to collect. Jaron, can you add that?
Yes. Yeah, sorry about that. I've been trying to talk and I've been muted, but we've done several PSAs statewide of getting back to wellness and also working with the hospital association, but we will definitely add that to our list. And I should have the data, nationwide data from the American Medical Association that conducted a survey with us as well. And I would be happy to share any information with Sarah that can distribute for your commission.
Great, thank you. Because I've heard that a lot with a lot of providers. We're seeing a need for, especially so in my specialty, mental health, behavioral health, and patients just not really understanding how to even access that type of care. So that would be great to get that data.
Absolutely.
This is Richard. If I may just add to Jessica, I think you make a great point. We can certainly pull from the payer side on Medicaid, like what the utilization is or has been, and we've posed that question just related to testing, and so I think other services as well. You make a great point, and we can pull that from the payer side, from the claims data.
Thank you.
Mr. Chair.
Yes.
Yeah, just a comment. It seems as though, and again, I appreciate Dr. Schwanger and the State Medical Association presenting today. Two things to keep in mind. One, that the issues around workforce go beyond physicians. Nurses, technologists, pharmacists, social workers, psychologists, on and on and on in our state, and addressing that is important. If there's anything that we've learned from COVID, I think that we have an opportunity as a commission address workforce issues to address the issues of reciprocity and the compact. And the third point is, if we've got a shortage now, vulnerable populations like those who are insured by Medicaid are only going to have worsened access over time if we have providers leaving the state or have to rely on contract labor. So I wanted to make those points as we address workforce issues moving forward for us.
Right, and I understand, Bob, that's perspective on trying to limit reimbursement for telehealth from a payer's perspective. But I have to say, we're all here because telehealth is this opportunity that we see that could really help these vulnerable populations, especially when they're facing barriers such as transportation, ability to even access their providers, et cetera. So, I mean, I would even posit, do we provide, I'm sure this is more controversial, but heightened rates for telehealth to just try to get more providers to use it, or just at least look at how do we reinforce providers' use of it in a state that really has a lack of providers and a hard time accessing to care.
I'd like to clarify. Can I clarify one of the things that we're trying to figure out? Is that okay, Mr. Chair? Sorry.
Absolutely, go ahead.
I think I don't know how the commercial insurance industry is handling this, and hopefully we can get representation from them because I can't speak for them. But we're a nonprofit health plan. We cover a lot of people in Southern Nevada, and we have our health center, and we're trying to figure out how to move that into a more virtual environment, kind of because we've been forced to under this model. Our patients would greatly prefer to show up at the doctor, be able to talk to the nurse, be able to see their doctor face to face, be able to ask related questions that the doctor didn't, that the call isn't about. It's hard to get them to transition to telehealth. So it's not just the providers, it's the patients. And the reason we would like it to be more affordable to do that is because one of our biggest problems is trying to figure out how to help our members make a copay for telehealth. So we essentially are trying not to have a copay at all, any cost share to the member for telehealth, because it's really difficult for the doctor and the patient to both be trying to figure out that copay piece of a virtual visit. The patient doesn't understand their bill. There's no one there to talk to. They can't pay the copay online. There's that big barrier of access with our populations, and particularly the ones that English isn't their first language. It's very tough. In addition, there's this layer of national telehealth programs like Teladoc versus our primary care docs in our community that are seeing that that's their regular patients. And I think those are two worlds we should be trying to figure out. So that's really what the payment issue is more about. If we can make it full affordable and not cost the member anything, we could do more of it. But again, I'm only speaking for our fund. I'm not speaking for the commercial insurance industry. I think this has been a good conversation. I'm hoping that somebody's going to go through the bill, like Jessica kind of inferred, like for other people. What's wrong with the state statute that is creating barriers that we actually as a PPC could try to address?
And I'd like to. This is a great discussion. I'm hesitant to stop, but we've got 4 or 5 speakers coming up who I think we continue that conversation. I want to be mindful of our time a little bit, but also the fact that Joan Hall has been patiently waiting to provide kind of a rural provider take on this. And I'd like to just say to the group that I've worked with Joan in Nevada Rural Hospitals for over 2 decades now. That dates me, Joan. But I think one of the things that we can get from Joan is not just her rural hospital members and their take on COVID-19, but the majority of her members have provider-based rural health clinics, and a good number of them also have skilled nursing facilities. So there's almost a continuum of care there that's represented from Joan's perspective. So Joan, take it away.
Thank you, John, and members of the commission. Thanks for allowing me to give you a rural perspective on the COVID pandemic. I'll also later be talking about telehealth, so I'll try not to intertwine the two. In your background information, you each should have received a map of Nevada Rural Hospital Partners. Just wanted you to have that because it's always amazing to me, people who don't realize where the rural hospitals are. All of our hospitals in our membership are critical access hospitals. And just to give you background so you'll understand some of our limitations, CMS limits the number of acute beds to 25 for critical access hospitals, an average length of stay of only 96 hours. So that provides some background to limitation during this pandemic. Also want you to know that 7 of our 12-member hospitals have distinct part long-term care, as Dr. Packham said. Those are long-term care facilities that don't have a bed limitation. So we have between 12 beds or 16 beds up to 49 bed units. Those are attached to the hospital. So it's like a wing in the hospital. So during this pandemic, a real vulnerable population that we were concerned about. Also, there's only 4 of our member hospitals that have intensive care units. Those are located in Fallon, in Gardnerville, in Winnemucca, and Ely. The rest don't. The rest might have ventilators, but they don't have the capability or the staff to keep ventilated patients. Additionally, just as background, 4 of our members, only 4 members, are served by public health districts. So the hospital in Yerington and Gardnerville are served by the Quad County Health District. Incline Village, tiny little hospital, is served by Washoe County Health District, and Boulder City Hospital is served by the Southern Nevada Health District. My presentation is a result of conversations with our members. We have been doing weekly infection control work group meetings, including CEOs, CNOs, infection preventionists, as well as members from DPBH, Healthcare Quality and Compliance, other state officials, as well as subject matter experts, because small hospitals have a difficult time assimilating so much information as it came out from CDC and CMS. And so we met weekly and discussed issues, the good, the bad, and the ugly. So I'm going to share some of that with you. Initially, well, and I just want to say, first and foremost, what I've witnessed is supreme dedication of hospital staff doing their darndest to take care of patients, make sure their communities were cared for. In most of these communities, there are no private providers. If it weren't for the employed physicians, nurse practitioners, and PAs that work in our rural health clinics or in our hospitals, there's no private practice people to go to in most of these communities. So in talking about staffing, we were acutely concerned if in Caliente, the only physician they had would have come down with COVID. Or in other communities, their nurse practitioners that run their clinics, their nurses. We didn't have any professional staff. We had a social worker who was sick. I do need to mention that. But mostly it was dietary and housekeeping staff still causing us great concern, and they were sick with COVID. But one of the first issues that we recognized was testing. And so getting tests, I think Pahrump and Fallon, both the first week had patients to be tested. Neither had the correct testing kits, the supplies, just the little swab and test tube that was required. So getting those was an issue. And then we recognized that there was no way to get those tests to the state lab. So DPBH stepped in and contracted with our commercial lab companies who had couriers that came out to us, but at that time couldn't do the testing. And they agreed to transport those tests to the state lab in Reno. Others now have come up with more innovative ways using laid off employees, not from hospitals, but from county or other jobs to transport these tests to Reno. And so that's worked for us. But still, we have issues getting testing kit supplies, either from the commercial laboratories or the state lab. Hospitals are making their own kits, but have difficulty even finding the supplies to buy to do that. We continue to have an extended time to get test results. Typically, it is 3 to 4 days. Often it is 5 to 7 days before we even get the results back. And recently, because we were doing the mandated long-term care residents and staff testing, we had 2 facilities that it was 14 days before they got the results back yet. So some issues there. It has shown us that we recognize the importance of having the state laboratory integrated into each rural hospital's lab system, even though that's an onerous task for us and a subject for another day's discussion, but that is really important to have that integration occur. As with the, also we did all the testing because we didn't have health departments to send these patients to. So it was the local doctors, nurses, lab techs who were testing these patients in drive-through testing centers set up by the hospitals, in parking lots, in special areas they devoted to this in some of the colder climates where outdoor wasn't so well received. Hospitals just did what needed to be done to test these patients. Someone was asking about patient satisfaction. That was probably one of the issues that we recognized early on, was dissatisfaction when statewide people or nationally people were saying, if you want to be tested, you can be tested. That really wasn't the fact, because we had to get a PUI number. And so even though physicians thought patients needed to be tested, we couldn't get that number for various reasons. Testing was limited and patients were irritated at that. We heard that a lot. As Dr. Lake talked about, PPE has been an issue. It still is an issue for most rural hospitals. Part of that is because even though we participate in national purchasing groups, we're all on allotment. And because we don't have intensive care units, we don't do a lot of surgeries. We have hospitals that do perform surgery, but everything that we could get was based on what we had purchased the year prior. And we could only get 10% of that amount. So now we needed much more than ever, and we were only getting 10% of what previously we got. So PPE was a huge issue and continues to be for many of our members. Had a conversation with the state, Julia Peak, last week. We've talked a lot with Jeff Haig from the state, and believe that some of our members probably aren't accessing the state supply correctly, because we've had communication issues, and I'll talk about that in a little bit as well. But heroes sprung up. UNR libraries produced 3D face shields for every single rural hospital, like 200, 300 a piece for every hospital. We shipped those out. That was wonderful. The local sewing groups, as everybody's heard nationally and locally, they're making face masks galore. God bless them. And then the prison system here in Northern Nevada hopped in when we couldn't find hand sanitizer, and they made hand gel based from the Bentley distillery. They stopped doing their vodka. They donated their alcohol to the prison system, and they made hand gel. So that was distributed throughout all of rural Nevada. They also made face masks and face shields. Talking about, I think Chris was talking about the way the stockpile is distributed, and we were very grateful for that. But I can tell you, as a nurse, when you only get 3X gowns because that's all that's available, that puts you probably at a greater disadvantage. Having that extra material to doff puts everybody at risk. Or receiving only small N95 masks. You know, those have to be tested, and small doesn't fit everyone. Large doesn't either. So there are just problems just in the whole distribution process. Also, we fell to the same thing Chris was talking about, is those black market sellers. When you're desperate, you buy from wherever you can get it. The cost we incurred was 2, 3, or 4, sometimes 5 times more than typically we had been spending. And then you get an inferior product at the end. So PPE continues to be an issue, and it's things that you wouldn't even expect. I mean, it's gloves, gowns, regular face masks that just simply aren't available. One of the things that we did recognize is that in the previous stockpiles, when SARS and Ebola was considered and there was distribution to rural areas, those supplies probably weren't needed at the time, and so were stored in non-environmentally controlled spaces. So a lot of the N95 that we had, the elastic deteriorated because of the heat and the cold, so made them unusable. Or we didn't rotate that stock, and so when it expired, this was in the day when it expired, you couldn't use it any longer. So when it expired, it was disposed of. Shameful to think about that now when we're reusing things that have an expiration date and reusing masks in ways that we never thought we could in the past. So what we've recognized, and with the CARES Act funds that some of the rural hospitals have received from the federal government, they're looking at environmentally controlled storage units and looking at a process to inventory stock that's in there, should we ever have a surplus of supplies again to put in there. One of the things also, and I'd like to recognize Director Whitley, because he really assisted rural hospitals in the ability to early on try to meet the surge that we expected might occur and use unused spaces in hospitals. Many of the hospitals in the 80s closed their labor and delivery or their surgery rooms, and we were able to retrofit them and use them for potential surge capacity. And so just a shout out and thanking Director Whitley for allowing us to go ahead and do that. Also, I think it's very admirable, all 12 of our members agreed that they would accept recovering COVID patients because we thought that there would be such a need for beds that acute care facilities would need to transfer these patients. Distance we thought was going to be an issue, but when we talked to Medicaid, we had some plans for how we could assist with the transfer. But all 12 hospitals had areas set up where they felt that they could safely care for recovering COVID patients should our tertiary hospitals, who always accept our transfers, needed that extra room. So thank goodness that didn't happen and we didn't need to do that, but we're still prepared in the future should that happen again. There was not a huge inpatient impact to our hospitals, with the exception of Humboldt General in Winnemucca. I think at your last commission meeting, there was discussion about the high rate per capita. Humboldt had the highest rate per capita in Nevada of positive patients in their community, followed by Lander County. Humboldt did have 4 patients that they had in their ICU intubated. All of those patients did require transfer to a tertiary facility for a higher level of care. Thank goodness we have had no positive in our long-term care facilities, our, as I said, our most vulnerable population. And I attribute that to the fact that we are attached to an acute care facility. As you heard Brett Solomon talk earlier, long-term care kind of got missed in this. They are a really essential provider and important. If you look at what happened in Washington State and New York, we certainly didn't want that to happen in Nevada. So Distinct Part Long-Term Care had access to the PPE within the hospital, albeit a small amount. We still had it there for them. We have the testing capability because our providers were right there to do the testing. And we share infection preventionists. So it was the hospital infection prevention policies and procedures that our long-term care is always educated on. So they were well-trained and ready to go. Sadly for long-term care residents, we quarantined them as CDC recommended early on. And so for the past 3 months, they've not seen family except maybe through windows or on Skype. They haven't had friends visit. They haven't had communal activities. They're in their rooms, putting a lot of stress on both the residents and the staff caring for them, trying to keep their spirits up and keep them eating. So it's been interesting for long-term care. We did develop some best practices with NHA and the Nevada Healthcare Association on testing required before we would accept residents from an acute facility. Probably not well received by everybody, but without a negative test, it was going to be difficult to get patients transferred into long-term care because then you had to quarantine them, you had to have a special area. So that was a challenge for us, but I think our members rose to that occasion. Also, just of note for this commission, we have a self-insured liability pool, and we were in the middle of renegotiation for our reinsurance. And it was alarming to me how many insurance companies said that they were no longer going to provide liability coverage for long-term care facilities because they brought such a risk. Some things that I think worked really well for us were community paramedicine, a community service. It was a grant we got from HRSA. We're just finishing up. It's in 3 communities, but in Winnemucca, it was phenomenal. Typically, it is an in-home visit, but we worked with Medicaid and they allowed us to just do telephonic visits. They reached out to 102 unique patients that were COVID positive and quarantined in their homes. They had a total of 522 visits monitoring these people using a standardized plan of care process, making sure that they had what they needed and that they were following doctor's orders, making sure that their health wasn't deteriorating. So that actually was really beneficial. Our hospitals also saw a huge decrease in the number of visits in our outpatient centers, our clinics, our diagnostic centers, and our ERs. From 30 to 60% is what our members have seen a decrease in. Yet the expenses that we needed to meet this need have increased twofold or threefold. We've done the social care to our patients via telemedicine, and I'll talk about that later, but we think it's been very beneficial. They're seeing their own doctors, patients like it, doctors like it, and it only happened that we could see our own patients because of a waiver that Medicare had. That's one thing that we would like to see continued, but that's a federal regulation, not a state. So that's what I have from the rural perspective. I would be happy to, one thing I forgot, one of the most important. One of the biggest things that we recognized is the whole public health process. Many of our communities didn't have public health officers. We used our county emergency managers differently during snowstorms or flooding than we did during this pandemic. The role of community health nurses and the hospitals, we've recognized that as a really important point to consider when ensuring statewide coordination and resources, because we think that sometimes we didn't get correct information. We probably ordered the PPE incorrectly, didn't go to the right person to get it. And there were just lots of moving targets that our members weren't aware of. So that's one of our biggest recommendations, is having better integration. And I'd be happy to answer any questions.
Thank you, Joan. Do commissioners have questions? Joan, you've answered every question.
Yeah.
Or does Bobette, do you have a question?
No.
Oh, you don't. Okay. Very good.
So, John, I was hoping, could I make a comment just along
Yes.
with what Joan was saying about the plight of the rural public health districts? In my region, which is Carson, Lyon, Douglas, Churchill, and Story counties, we've seen a limited ability for the public health districts to be able to respond to behavioral health as well. So they're really already pretty maxed out. And then, I heard a statistic the other day that anxiety, so for Nevadans, anxiety and depression has tripled over the past year due to the COVID epidemic. And so we believe that we see this silent crisis, and that crisis is not really able to be addressed by even these public health districts in the rurals that have been set up, the Quad County, let alone a lot of these places that don't really even have infrastructure set up at all. So I just wanted to highlight Joan's comment on that.
Yeah. This is Dr. Khan. If I may, I have a quick question.
Sure.
I heard about the challenges of PPEs availability in the rural areas. My understanding has been that the governor's task force that still is in place had arranged for PPEs to be distributed around the state. And at one point, the needs were all fulfilled, if I remember correctly. Is that not the case, or was it not the case with the rural areas?
We did receive some of the stockpile, absolutely. some of that was, some of the issues were what I was talking about. The 3X gowns were all that were available. Those are difficult to work with if you're not size 3X or only small N95. And with both long-term care and doing the testing, those supplies were used very rapidly. So we did get distributions, but we still have many. Last Friday on our call, there were 6 facilities who still have a dire need for some supplies.
So I presume that's been brought to the attention of the task force?
Yes, yes. In fact, Julia Peak sent me an email this morning saying, try this. Here's a way to try to order and get things from the task force. We also have a member of our staff who is in charge of our purchasing group, who sits on one of the task forces put together to look at purchasing. And so she works on that as well.
All right, thank you.
Chairman, I have a comment.
Yes, go ahead.
Bohannon for the record. I just want to go back to what Commissioner Flood just mentioned about the public health in the rural communities. And I think that we're hearing it from the provider standpoint, and I can speak as somebody who worked in public health that I don't think that those are problems that will get solved immediately. And maybe Richard can speak to it in greater detail, but I think that there would be a significant challenge in building a public health workforce in rural communities. I know there's a challenge getting providers in rural communities. And even now as we're ramping up, the approach has been contract workers for public health, and that there's significant limitations with having our approach be contract and trying to fill a need after a pandemic. Obviously, an ounce of prevention goes a long way, no pun intended. So I just kind of want to generally make this comment that if we don't value public health and we don't value the professionals in that workforce, we're going to constantly be playing this catch-up game. And it's going to specifically hit, I think, rural communities harder than it might hit in our more urban settings.
Thank you for that comment. We agree with that. We also think that we should step up to the table more. I think, like I said, we haven't always been as involved as we should have as a hospital, and have recognized that we need to do that because there is certainly a limitation.
All right. Any other questions for Joan? Thank you so much. We are now at the bottom of the hour, and I would like to take a very brief break. Microsoft tells me it's 11:29. I'd like for us to reconvene at 11:40 and take up our discussion and presentations on telehealth services. All right?
Great. Thank you, Mr. Chairman.
Thank you.
Thank you.
All right, folks, I'd like to get started in a minute. Commissioners are on. Please turn your cameras on so I can see if you have rejoined us.
William Van Houweling, V-A-N-H.
Fellow commissioners, are you there?
I'm here, Mr. Packham. This is Mason Van Houweling.
Hi, Mason. So I see Teresa, Sean, Mason, Dr. Khan, Yarleni, Jessica. I've learned in life there's no such thing as a 10-minute break, but we almost did it, so. Sarah, are you there?
Barbara Richardson's here.
Hi, Barbara. Thank you. Leslie, are we able to proceed or do you need Sarah? Can't hear you. I can't hear you. You're muted.
Sorry, I can't control it from my
Okay, we'll wait a second.
my desk here. She'll be back any minute, I'm sure.
Okay. While we're waiting, Megan, are you ready to rock and roll?
I am.
Okay, very good. Hello. All right, Megan, I think we are ready to go.
Okay, let me share my screen. Okay, can you see that?
Yes.
Excellent, that's exciting. Well, good morning, Mr. Chair and members of the commission. Thanks for giving me the opportunity to present this morning. My name is Megan Komlassi. I'm a principal policy analyst with the research division of the Legislative Council Bureau. We are the nonpartisan staff agency that serves the Nevada legislature. And as nonpartisan staff, I neither advocate for nor against any issue, policy, or position, but I am happy to be here to provide some information to you today. I'm going to talk about three primary things: key telehealth legislation in Nevada, policy options related to telehealth, and then considerations for post-COVID-19 as you start thinking about moving forward. So the vast majority of our telehealth laws were passed actually in 2015. But before we get there, I wanted to mention Senate Bill 327 from the 2013 legislative session, because it's really a precursor to current telehealth laws, and some of its provisions remain in Nevada revised statutes. SB 327 revised the definition of practice of medicine to apply regardless of practitioner location. It authorized physicians and with a special purpose license, as well as APRNs, to practice regardless of location by using equipment that transfers information electronically, telephonically, or by fiber optics. It also made various changes governing the practice of telemedicine for osteopathic physicians. However, many of those provisions were superseded by the 2015 legislation. And then it made changes related to telepharmacy in Nevada. And we have a set of pretty established telepharmacy laws and regulations in Nevada. I'm not going to go into those today, but they do exist, and I'd be happy to follow up with more information about that if you're interested. I did want to note, though, that SB 327 included one provision related to telepharmacy that clarified that the bona fide relationship that's required to prescribe a controlled substance exists if a patient is examined in person, electronically, telephonically, or by fiber optics within or outside Nevada or the US. So then in 2015, Nevada passed AB 292, establishing our current telehealth laws, in which you've heard mentioned this morning. And I think before we talk about it, it's helpful to understand the context in which the bill was developed and passed. So in 2015, the health insurance provisions of the Affordable Care Act went into effect. Nevada expanded Medicaid, and the Silver State Health Insurance Exchange went live. And so we saw a significant increase in the number of folks who had health insurance. The uninsured rate decreased from 23% to 11%. So had many more people with health insurance coverage. So having actual insurance to access care was no longer an issue. However, actually getting in to see a provider still was a barrier for a number of Nevadans. And that was due in part to the severe shortage of healthcare professionals that we faced back in 2015, 2014, and we continue to face today. On top of that, the state faced and continues to face challenges attracting and retaining providers. And so this bill was sponsored by Assemblyman James Oscarson, who worked with a group of approximately 30 stakeholders for more than a year to develop the legislation. And their goal was to capitalize on the opportunity technology provided in order to expand access to healthcare to all Nevadans. And telehealth was not new at that point, but the group recognized that there were gaps in service that telehealth could help address. And then also that implementation of a formal policy could be beneficial to the state as well. So there are three primary portions to this bill. AB 292 includes legislative findings and declarations, which is not super common in legislation in Nevada, so it's meaningful. It also includes requirements for healthcare providers who are providing telehealth, as well as requirements for health insurance policies and plans who offer health insurance in Nevada. First, the findings and declarations essentially just say that healthcare provided through telehealth are as effective as care that's provided in person, and that telehealth doesn't reduce the quality of care or the relationship between patients and providers. And I know we've had some discussion about that this morning already as well. The declarations also declare it to be the public policy of the state to encourage and facilitate the provision of services through telehealth, to improve public health and quality of care, and to reduce the cost of care, as well as to ensure that services are covered by policies of health insurance to the same extent as those provided in person. And this is an issue that it relates to parity, so coverage parity, and it's something that we'll talk about more in a minute. The bill defined key terms: telehealth, distant site, originating site. Of note, the definition of telehealth does not include services provided over the phone, fax, or email. And so getting into telehealth requirements for providers, these are outlined in NRS 629.515. They require a provider to be licensed in Nevada in order to provide telehealth services. It provides that these providers are subject to Nevada laws and regulations and must comply with laws as if they were practicing in the state. Nothing in the law expands a provider's scope of practice, and these requirements apply to all providers of healthcare as defined in NRS 629.031. So the requirements that you see on this slide apply to all of these providers of healthcare. And so you'll have that list that you can look back at. So we'll move on to the insurance coverage requirements. And I apologize, I know there's a lot of text on these slides, but figured it would be helpful to have this to refer back to since it's fairly technical. AB 292 provides various health insurance related chapters of NRS as well. It requires pretty much all state regulated health insurance, including Medicaid and workers' comp, to cover telehealth services to the same extent as services provided in person. This is the coverage parity issue. And as all states have been grappling with how to deal with telehealth, many didn't have as established of laws. And this is one issue that a number of states are moving forward to address, is this parity in coverage. The bill also prohibits an insurer from requiring, as a condition of providing coverage, an insured to establish a relationship in person with the healthcare provider or to provide any additional consent or reason for obtaining telehealth services, or a healthcare provider to demonstrate that it is necessary to provide services via telehealth, or receive any additional certification or license to provide services through telehealth, or that covered services be provided through telehealth. So pretty specific requirements for insurers. It also prohibits an insurer from refusing to provide coverage for telehealth services based on the distant site or originating site. This is also something that other states are looking at this point, because many states had laws that dictated where a patient or a provider could be when providing telehealth. And importantly, within the insurance coverage chapters, the definition of provider of healthcare actually points to NRS 439.820, where a provider of healthcare means a person who is licensed, certified, or otherwise authorized by the laws of the state to administer healthcare in the ordinary course of business or practice of a profession. So it's a different definition than the definition of provider of healthcare used related to the provider requirements, if that makes sense. A couple other health insurance requirements: prior authorization. The bill prohibited insurers from requiring prior authorization for telehealth if it's not required for the same services when they're provided in person. But on the flip side, it also authorized prior authorization for telehealth if it's also required for in-person services. So there's kind of parity with prior authorization. It clarified that insurers aren't required to ensure covered services are available through telehealth at a particular originating site, provide coverage for a service that's not a covered service or not provided by a covered healthcare provider, or to enter into a contract with any provider or cover any service if it's not otherwise required by law. And finally, the bill requires the Commissioner of Insurance to include telehealth services in making network adequacy determinations. So that was a lot of information about our current telehealth laws, and I'd be happy to answer any questions about that maybe after we go through the policy options. But I think I would just say that clearly telehealth has been gaining momentum in recent years, but the COVID-19 pandemic has really accelerated the pace of uptake across the state and the nation, and provided an opportunity to test the legislation that was passed in 2015. And it seems like to a large extent, the framework has held up pretty well. A number of states and even the federal government have taken action to encourage or increase the use of telehealth. And in doing so, they're implementing some of the same types of provisions that we already have on the books. That said, there's also room for improvement. And I think you've heard about some of that already this morning. So in talking about policy options to improve and expand telehealth, I think it's the framework with which I was thinking about it was the challenges and barriers, which fall into two main categories: challenges related to providing telehealth and challenges related to accessing it. And I'll just note that I am not an expert in telehealth, but these policy options were pulled from reports by experts in this issue. And at the end of my presentation, I included a slide with a number of the resources that have more information if you are interested in getting more detailed information. Also happy to pull information together for you if you're interested. These are also not exhaustive, and I'm sure you'll hear some more from the next presenters. Specifically didn't include much about Medicaid since Suzanne Bierman is going to present next, but hopefully these will provide a place for you to start. So these include actions taken to amend telehealth laws and regulations in other states through regulation, executive orders, and agency directives. Some of them are temporary, lasting only the duration of the public health emergency. Others are permanent, and some of those permanent policies existed prior to the pandemic, and others have been enacted in response to the pandemic. So just looking at the first bullet here on this slide, according to the Council of State Governments, interstate licensure has been one of the largest barriers to broad adoption of telehealth by healthcare providers. And during this emergency, nearly every state, including Nevada, is temporarily waiving licensing requirements for out-of-state providers so that providers with equivalent licenses in other states can practice via telehealth. And the Federation of State Medical Boards is tracking those policies. I think at this point, 49 states have that type of policy. In Nevada, Governor Sisolak, his declaration of emergency, Directive number 11, temporarily suspends state licensing requirements, and providers in good standing in another state just need to notify the appropriate licensing board in Nevada for them to confirm their home state license. And so similarly in other states, these types of waivers of state licensing requirements are temporary, and most of them have been done through executive order or directive. But there are legislative options as well to reducing unnecessary barriers to licensure. And one of those is through pursuing interstate medical licensure compacts. Nevada has ratified 2 for healthcare professionals: the Interstate Medical Licensure Compact in 2015 and the Psychology Interjurisdictional Compact in 2017. And so these compacts are established to streamline licensure processes for these professionals. Essentially, if you're licensed in one state who's a party to the compact, it's easier to become licensed in another member state. And while compacts expedite licensure, they don't remove or eliminate all barriers to licensure, but they are helpful. There are 5 other interstate compacts that exist in the US that relate to health care professionals. There's one for APRNs, EMS personnel, nurses, physical therapists, and audiology and speech language pathology. And I would imagine that we'll see legislation proposing to enact at least one of those in the next legislative session. Parity, the next bullet, is also a huge issue when it comes to telehealth, and there are two primary issues around parity. There's coverage parity and parity in reimbursement. Nevada already has coverage parity, so just the provision that requires insurers to cover telehealth services to the same extent as if they were provided in person. But at least 10 states have payment parity as well, and you see those listed on the slide. And so these states are reimbursing telehealth at the same rate as equivalent in-person services, because telehealth is often reimbursed at a lower rate than in-person services. And actually, reimbursement parity was included in the original version of AB 292 when it was introduced, but it was amended out of the bill prior to passage. This requirement for payment parity is typically included in legislation. So actually all 10 of these states have passed laws requiring payment parity for telehealth. And so they're permanent requirements, it's not temporary. And I would say, as with any policy, there are pros and cons. There are arguments that have been made that payment parity helps expand access to care for patients because it helps incentivize providers to offer this model. And there are others who argue that that increases spending. And I think you have had some of that discussion already today, but definitely an issue that many states are considering. Another option, or another thing states are doing, are limiting or eliminating cost sharing requirements for telehealth. And these policy changes have primarily been implemented through executive order, agency directive, or emergency regulation at this point. And states are taking different approaches. So some are requiring insurers to cover telehealth with cost sharing that's no greater than cost sharing that applies to in-person services. Others are requiring cost sharing for telehealth that's lower than services provided in person. Some require coverage of telehealth without any cost sharing, and others are just encouraging but not requiring health plans to waive cost sharing requirements. Broadband access is another challenge to both providing and accessing telehealth, particularly in rural areas where telehealth could be most beneficial due to the lack of providers. And I'm sure you'll hear more about broadband when Bill and Joan talk again a little later. But a few other states are looking to improve broadband by promoting universal access to high-speed broadband and supporting infrastructure development projects, as well as creating broadband ecosystems that align hospitals, schools, and libraries to create a telehealth care type hub. So just a couple of things other states are doing there. I also wanted to mention Senate Bill 53 from the 2017 legislative session, which created the Office of Science, Innovation, and Technology within the governor's office. The bill required the director of the office to develop a strategic plan for broadband and expand telehealth services to increase access to care, among other requirements. And the office issued a report on telehealth and broadband in 2018. So if you're not already working with the office, it may be a good partner to engage. In addition, both states and the federal government are pursuing the use of audio-only telehealth visits. So services provided over the phone, which can help improve access for patients who don't have access to live video technology, whether that's due to a lack of broadband or income or experience with technology or a person's willingness to use it. So that's something to consider. States are also investing in telecommunications and telehealth infrastructure for providers who may not be able to afford it, especially to facilitate access in rural areas. And this may include providing direct funding for small health systems or smaller practices to implement telemedicine. And then finally, I think another piece that you've touched on a lot today relates to data and really just collecting data to help inform and support post-pandemic use of telehealth. Similar to Nevada, states are considering whether to extend pandemic-related policies to improve access to care in underserved areas, even after the emergency is over. And I think to help determine which policies to extend, it could be helpful to look at data and identify gaps in access to really determine the effectiveness of and shape policy in the future. So that might mean looking at communities without broadband or families and neighborhoods without wireless connections, which could be really important to building more equitable telehealth infrastructure and improving outcomes in underserved communities. And finally, I'll just leave you with a couple of considerations. It seems like telehealth policy or telehealth is here to stay, and it's something that's going to become a larger part of our healthcare system than it ever has been in the past. And so as you consider what policies may be best to encourage or facilitate telehealth, it's important to think about the right balance of coverage, reimbursement, and medical management policies, as well as how to ensure that the policies reduce and don't exacerbate existing inequities in access to care. So just a couple of things to keep in mind. And with that, you've got a few resources there, my contact information, and I'd be happy to answer any questions.
Any questions for Megan?
Hi, Megan. This is Howard Barron for the record. Thank you for the very, very nice comprehensive report. You mentioned when you were discussing parity in payment that one of the original bills, and I can't remember if it was 282 or which number you referred to, included something about payment parity, but then it was stricken prior to the final language coming out. And forgive me for not remembering exactly where that discussion centered, but do you remember the specifics of why it was stricken and you know, sort of the argument for and against in that particular case?
So you're right, it was AB 292 in 2015. And I don't know that I reviewed the minutes about that in particular, but I'm pretty sure it was a similar conversation to that which you had today. You know, an issue of payers and payers not being on the same page necessarily. I think that was probably one of the biggest sticking points. It was probably easier to strike that language and keep the bill moving forward than not.
Okay, great, thanks. And I was just going to comment, Chairman, if I could, that if you know, and again, with the goal here being primarily to improve access to care, payment parity or reimbursement parity, I guess, for telehealth to me makes sense, of course, as a provider of healthcare, but it also doesn't make fiscal. It doesn't seem like it would be a fiscal burden to the payers from the standpoint that it improves access for their patients to access care, and we're not asking to reimburse telehealth higher than in-person visits. And so it seems to me that the difference is either the person has the access and maybe telehealth is the only way they can have it, or they don't have the access at all, in which case I guess neither the payer nor the provider of care is out that time or money. But again, if our goal is to improve patients' access to care, it would seem like it would be a good investment. Just my 2 cents worth.
Well, and if it's providing care more efficiently, there's that consideration as well.
So this is Dr. Khan. I have a comment also somewhat on similar lines as Dr. Barron, is that I'm afraid at some point the providers may choose not to do telemedicine because of the payment disparity and end up basically sort of indirectly forcing the patient to come in person, and the patient may not feel comfortable coming in person because of the COVID situation that we are seeing. So I think that needs to be seriously looked at. in the interest of the patient and also access. And at some point, the providers may choose not to provide services at all based on that. And again, it becomes a serious access issue also. I'm not sure whether any of that is happening right now, but I'm afraid that's where it'll head.
Chairman, it's Babette Bond.
Yes.
I have a question. Megan, is there any data showing what's happened since there was a change in who could provide telehealth across state lines with or without a license in Nevada? I don't know how many were doing it with the law in place that you had to be licensed in Nevada, and then what's happened since, and if there's been an impact on that. I think that's an interesting part of the bill we should really understand impact on.
I think that's a great question, and I have not seen any data, but I'd be happy to see what we can find.
Okay.
That would be great. Oh, go for it, Babette.
And I think the other issue, I wasn't involved in this bill either session. Our people were not involved in it, but I know that there's been a long history just for this group of hesitancy to mandate payment in state statute because it's a contract issue. And I think, you know, saying that it's more efficient to do it is that's a long chapter of research that we need to do to see if that's true. But I know that in both Republican and Democratic legislatures and under both Democratic and Republican leadership, there's been a reticence in Nevada to mandate contract rates because they could be negotiated. Doctors could be negotiating how much they want to get paid for telehealth right now and how much and if they're wanting to do it based on a payment. So I think it's complicated to start mandating, and I think it's a long conversation. And I'm not saying we wouldn't support it. I'm not saying we shouldn't try it. I'm not saying we shouldn't push it forward, but I think it would be helpful, Megan, with your experience to talk about that debate. I mean, Bill Welch and I have been on different sides of this for a long, long time now. I think what we don't want to do is waste our time. We want to do something that'll work.
And I'd also be happy to follow up with some information on what the conversation was, if there is any on the record related to AB 292 and that provision.
Great. Well, and so I just wanted to say, I thought, Bob, that you had a good point with local providers versus national providers. And so when you try to create, you know, incentives for telehealth, are we just bringing a whole bunch of national providers in as well? So I don't know if we could look into any, you know, what states have done in other areas in how to kind of protect our state providers.
So this is Dr. Khan. Just to follow up on that same discussion, what is the status right now of these out-of-state providers under this new temporary licensure situation? They technically would be out of network for the insurers that have provider networks in state. So what happens if out-of-state physician is providing a telemedicine service and is not a provider on the network of a particular managed care organization?
Also a great question, and happy to look into it.
And Megan, this is, Mr. Chair, this is Sean Shaner. Can I ask a question really quick?
Absolutely.
I just want to clarify one piece of information, Megan, if you don't mind. With respect to NRS laws that are passed, those would only govern fully insured business and not necessarily govern ASO self-funded business, correct?
Yeah, thank you for clarifying that. And I meant to mention that all of the Nevada regulated insurance plans, are not the fully funded self-insured ERISA plans. So what our laws apply to are a fraction of the entire health insurance market.
Do you happen to know what fraction that is by chance?
Yeah, it's something around 30 or 40%, and I don't know the exact number, but it's right in that ballpark.
The law, just to clarify, the laws would pertain to 30 to 40% of the population, leaving 60 to 70 not addressed by the laws.
Correct. And that's an issue we run into in any legislation that's passed related to insurance. It applies to a fraction of the market.
But I have to say it doesn't apply to the fraction of the provider market because the same providers
are the number of providers available in the state, period. And so they live, I think that sometimes we get the conversation confused about benefits versus reimbursement, because those doctors do want parity and a reimbursement by the entire market. And there's only so many providers. There aren't providers that only, well, there are some, but mostly it's a provider market that decides this instead of just self-insured versus commercial insured. They're sharing with the providers.
And another thing to mention, I think, on that issue is that when the state mandates something for state regulated insurance, I think often the hope is that the ERISA plans will voluntarily do the same thing. And that is not always the case, but it's something that legislators often mention, if we do this, then hopefully the others will come along as well.
And that would be good data too, because I think having lived through it on our side as a self-funded plan, we do feel that pressure when the market's moving to be part of the market.
All right, any additional questions before we move on to our next speaker? Thank you very much, Megan. I'd like to continue on with Suzanne Behrman, who is going to provide us with a little more information on the current policy landscape as it pertains to Medicaid. Welcome, Suzanne.
Great, thank you. Well, thanks for the opportunity to talk with you all today. I really appreciate it. And nice to follow Megan. She did a great setup of some of the issues that I hope to discuss today, but we'll certainly layer in a little bit of additional information about Medicaid, and also being cognizant of time. Some of this information is just more for reference and don't have to step through all of it. Next slide, please. Okay, so today, again, kind of similar in structure to the presentation we just heard, wanted to talk a little bit about Medicaid's telehealth definitions, a little bit of additional information about our policy, both before and now during the COVID-19 pandemic, certainly acknowledging and focusing on some additional flexibility that has been available to states throughout the course of this public health emergency. And then just wanted to acknowledge the conversation that just happened a little bit, that there are lots of conversations happening about the expansions of telehealth and what might be helpful to remain in place once the public health emergency has ended. So on this piece, just wanted to note that we are in conversations with the National Association of Medicaid Directors. That's the association that represents state Medicaid programs, and are also fortunate to be a part of the West Coast Compact for Health, which is a consortium of Western states, Oregon, Washington, California, Colorado, and now Nevada, following the governor's Western States Pact. When he joined that, we were able to join the subgroup that's focusing on some health issues, and that group has taken up telehealth. So working with some of our Western regional partners, other states in the Western region, to think through telehealth and how we might approach the federal government as more than one state around which of these policies we think would be helpful to see maintained post-public health emergency. Next slide, please. Okay, so here is the Nevada Medicaid definition of telehealth. I think it's pretty similar to ones that you've heard before, but wanted to provide this just for reference. Next slide, please. Okay, and then this is something I did want to spend some time on. The federal government has actually given states historically quite a lot of leeway in terms of telehealth and a lot of flexibility in terms of how states set up their telehealth systems. So states have the option to determine whether or not they use telehealth, which services are covered, where in the state it's used, and how it's implemented, along with which providers are covered and reimbursement rates. So again, I think this explains some cross-state Medicaid variation. So just wanted to highlight that CMS has historically given states a lot of flexibility and space in how they set up their Medicaid programs. Next slide. So building off of what Ms. Kamwasi and Mr. Welch talked about, just wanted to acknowledge and recognize that Nevada has a long history of supporting and promoting telehealth. Was in a 2018 study performed by Manat Health, was classified as a progressive state in all 6 of the domains that they looked into. And those included things like practice standards and licensure, Medicaid coverage and reimbursement, Medicaid eligible patient settings, Medicaid eligible provider types, Medicaid eligible technologies, and Medicaid service limitations. And so again, back to having a lot of flexibility, and given a lot of the work that's been done historically here in Nevada, just wanted to acknowledge that even pre-COVID, the state has been recognized nationally for having a robust series of telehealth services. So yeah, that's fine. Okay, so this one just provides a little bit of information on who can practice telehealth and provides, again, some national context around telehealth. And so Nevada is one of 19 states that don't put restrictions on which healthcare providers can use telehealth technology. So just wanted to highlight this. This is all came out of a recent MACPAC study that was done in June of 2020, just kind of looking at the national telehealth landscape and how things had changed in response to COVID. So just wanted to put a little bit of additional context on where Nevada stands among the states. So here, any providers can use telehealth as long as it falls within their scope of practice. And providers are still required to maintain best practice standards and perform services that are clinically appropriate and within the scope of practice as defined by their appropriate licensing board. And so I do want to also caveat that this first series of slides is primarily pre-telehealth. So there are some things where I'll caveat that where our policies have changed in response to COVID-19. Next slide, please. Okay, so around the types of services we cover in Nevada Medicaid, we cover both two-way video conferencing and store and forward telehealth modes. So as Ms. Kamwasi mentioned about herself, also true of me that I am not a telehealth or an IT expert, so I can't get super deep in some of these issues, but did just want to acknowledge that these are the 2 types of modes that we currently cover. Okay, and again, mostly just for reference, but did want to provide information on sites where telehealth is covered. And there's a list there. And so some of this has changed post-COVID, but our general policy is that we didn't provide reimbursement for telephone calls, faxes, text messages, or electronic mail. There has been some additional federal flexibility. I believe in the NHA presentation earlier, they mentioned 1135 waivers and blanket waivers that have been allowed by HHS during the time of a public health emergency. And some of that has broadened the ability to use telephonic modes of telehealth services. So just wanted to call that out as not something that was typically covered in our policy, but we have made some expansions during the public health emergency. So again, pre-COVID, these were some of the particular services that weren't covered under Nevada Medicaid for telehealth. I will say PSR in particular, I know for a limited population of children has been expanded after consulting with clinical experts and really wanting to both promote social distancing and make sure that children were able to receive continuity of care during this time. We have made some expansions. So again, this is kind of a pre-COVID-19 Medicaid policy snapshot. So wanted to point out that some of these have changed during COVID-19, and also to mention that any of these expansions that were due to 1135 authority under HHS will expire and go away at the time that the public health emergency ends. And so assuming that no additional action is taken by the Secretary of HHS, these additional flexibilities are set to sunset on July 25th. So again, back to having the conversations in a timely manner and states trying to discuss these issues both internally and among other states and regional states to approach the federal government. And I know providers are also engaged in this work at the national level, and that there's also a number of bills before Congress trying to address the gains that have been made in telehealth during COVID-19 and trying to preserve some of those. Okay, so again, this one is rather technical, but just some information on how the originating site and distant site pieces of telehealth work. I'm sure the providers that are involved and part of this commission are very familiar with this, but did just want to provide this for reference. Okay, I won't go into this, but I can tell you we have many, many details, and from providers get lots of questions around how do you bill for telehealth, and took out a couple of slides that went through all of the HCPCS codes and things like that, but did just want to reference that we have pretty robust resources on our website that outline both our telehealth policy and provide pretty specific guidance around telehealth billing. Okay, so here's some more information. The source again is MACPAC, which is that advisory agency to Congress around how states have been responding to COVID-19. So one of the findings in that report was that 44 states, excuse me, including Nevada, have expanded the types of services that could be delivered using telehealth. And they found that among the states, the greatest expansion was for the therapies, physical speech and occupational therapy, which previously hadn't been allowed via telehealth, and that's true for Nevada Medicaid, but we have made that expansion along with 43 other states. There's also an expansion in states who are now allowing home as an originating site. This was a new policy in 26 of the 47 states. And as I mentioned previously, Nevada added the telephonic modality for telehealth. And just a note here on the payment parity issue, 32 states during COVID-19 require payment parity for in-person and telehealth services in their Medicaid programs. And this last bullet, I think, is just building off what Ms. Komlasi mentioned too, that there have been pretty extraordinary gains in the use of telehealth throughout the COVID pandemic, and lots of interest both by providers and I think at the state level, as well as interest at the federal level in how to continue some of this. And you know, the phrase, the genie's been let out of the bottle, keeps getting thrown around a lot. So I think that is the primary question now, is to what extent does the expansions and gains that have been made during the public health emergency, to what extent are they able to remain in place? Okay, so this one's really pretty detailed, and we do have this all posted on our website, have pretty robust resources again outlining how we have dealt with COVID-19, but this is just a list of some of the things that we have done in the telehealth space to address COVID-19. So along with additional flexibility allowed by the federal government under that 1135 authority, has resulted in new platforms which previously weren't allowed, such as Skype, FaceTime, and audio only to be available, whereas previously they weren't. And that's again another provision that is set to sunset with the public health emergency. So I wanted to just flag that. Telephonic restrictions we've lifted, I mentioned that previously. We have expanded it for a variety of therapies, which is mentioned here, as well as applied behavioral health analysis, home health agencies and hospice agencies, and some of our long-term services and supports that typically required in-person assessments have been moved to telehealth under what's called Appendix K authority for 1915C home and community-based services waivers to ensure, again, continuity of care without increased risks and in order to promote social distancing. So changes have been made to those waiver programs to allow telehealth assessments to ensure that care is able to be continued during this period. Also, as I previously mentioned, the psychosocial rehab services are now allowed under telehealth for those under the age of 18. Okay, so as I mentioned before, we have huge library of resources available on our webpage that provide really granular detail on how we've operationalized this, how you can bill for it. So just wanted to provide all of these resources. And again, some of our own internal resources here, like our billing guide and our Medicaid services manual, but did want to also flag some Medicaid at the federal government resources that are here, as well as the Center for Connected Health Policy and some other national telehealth resource centers. So again, just provided this for additional reference and resource. Okay. Well, that was a lot, so I'll pause and see if anyone has questions. And again, thank you for the opportunity to talk with you all today. I think it's a really critical topic. And again, in terms of promoting access to care in a state that has some of the challenges that Nevada does, I just think, you know, an essential conversation, and happy to be a part of it.
Thank you. Any questions for Suzanne? I'll start off. I have one. I think I know the answer to this, but refresh my memory. Is the public health emergency set to expire on July 25th? Is that the?
Currently. Yes.
And with respect to the changes that you've outlined here, does that mean all of those will expire on July 25th, barring any changes, or?
It does, and there's a really great resource I can provide that kind of outlines all of the authorities and the expiration dates. The one caveat I would make would be those home and community-based services, Appendix K changes that I noted very briefly. Those actually don't expire until January of 2021, but almost all of the others that have been highlighted in this presentation are set to expire with the public health emergency. And again, happy to provide that. It's a 1 or 2 page front and back resource of all the different authorities by which additional flexibilities have been allowed and their current sunset date. So I find that to be a pretty handy resource, and I'm happy to share that.
Oh, any piece of paper without a staple in it sounds great. Okay. Yeah, that would be nice if you could share that with us, just because I think if that date ended up pushing out, we at least know what's in jeopardy of sunsetting. So,
right.
Other questions? Babette.
Chairman, this is Howard Barron for the record. Suzanne, thank you very much for the presentation. 2 questions. One is, has the ability to provide these services, whether it be by telephone or by a telemedicine visit, has that substantially affected the budget of our state Medicaid? And going forward, do you anticipate that it will be a crucial issue, given the governor has already said that almost all state agencies are going to have some significant decrease in their funding? That was one question. The other is, are there any grant opportunities at a federal level for our state Medicaid program to engage in that might help expand telemedicine services?
So both really, really good questions. The first one, we are keeping a close eye on our data. However, we have about a 90-day at least claims lag. Really, claims can come in throughout the course of a year, but we have a good number usually in after 90 days. So we are monitoring the utilization rates for telehealth. And I can tell you, based on very preliminary data, we have seen a very large increase in telehealth utilization that also has been accompanied by big decreases in other areas of utilization, as we've heard this morning, as I know many of you are feeling and living every day. So that is something that we're monitoring quite closely at the national level, based on some national level resources, Fair Health and others. I'm trying to think of some of the data sources. Nationally, they haven't seen that the telehealth increases make up for the decreases in other areas of utilization. And we are monitoring that, but our data is just not complete yet, but something that we definitely are keeping an eye on and would be happy to report back on that issue. Your other question about grant funding is also a really good one. For Medicaid, the primary benefit that we've had from federal legislation came under the Families First Coronavirus Response Act, and that provided an enhanced 6.2% enhancement to the state's matching rate for Medicaid. So a number of our eligibility categories got an enhancement in the share that the feds pay, with them paying an additional 6%. And that's been really critically helpful as we've seen increases in our caseload due to the COVID pandemic and the accompanying unemployment crisis that has come along with that. So that's been the primary way that the Medicaid program has gotten some assistance from the federal government. We are hopeful that there's an additional enhancement of federal funding. So some of the grant funded programs, I think, typically go to public health, public and behavioral health. And for us, it's really been that enhanced matching rate that's been critical.
Other questions? Babette? I think you're on mute, Babette.
Thank you. I thought that was really helpful. Thank you for the presentation. On your last page on the top bullet where you talk about some of the current barriers that have been lifted are Skype and FaceTime and I'm assuming text because telephone. Our members have had a hard time with trying to adopt telehealth programs, and we can spend time on that. There's several reasons for it, but Skype and FaceTime and texting have been like a big game changer for us in terms of what our patients can access because they use FaceTime and they have a phone and they are doing texting. And I'm wondering if that's going to terminate when the emergency is no longer considered an emergency and Medicaid will lose that access. Is there anything that can be done at a state level, or does that require a special waiver to keep that? Because I think it's been so important to getting this stuff lifted, at least for our people. And I would love to hear if the doctors have found the same.
Yeah, also a great question. My understanding is that that flexibility came again through the 1135 waiver authority. The federal government and the Secretary of HHS had some flexibility around HIPAA, Medicare, Medicaid, and CHIP. And so it was that authority that allowed them to waive certain provisions of HIPAA, which is what my understanding of what's made this possible during this time, so that then when the public health emergency goes away and that 1135 waiver authority expires, that flexibility will also expire. And my understanding is that it likely will take congressional action at the federal level to be able to maintain that, since it's HIPAA related.
So that's everybody. That's private sector, public sector, commercial, self-funded. That's everybody.
My understanding.
Other questions? I see Teresa.
Yeah, I want to go back to the previous presentation on telehealth, and on the last page there was a bullet about it, telehealth could exacerbate some of the inequalities that exist in our society. And I think that with school closures, we saw that pretty significantly with families that have access to broadband, families that have, access to the technology that's needed for telehealth. And my concern for patients, and I'd be interested if there is any data out there in terms of who isn't able to access telehealth. And I think that beyond the economic inequality, there will also be inequalities among various patient types. Just for a personal example, my son can't get an EKG via telehealth. So I think that there are a lot of inequalities that could exist with telehealth. And while I'm the first cheerleader for it, I think we don't want to fall into this idea that it's a panacea. So I'm just curious if there has been any research or studies done to look at what those inequalities look like for our state, and what we could do to address them so that there is equal access for patients. If more providers are moving in this direction, either for pandemics or just given that there'll be a broad adoption of telehealth.
So this is Suzanne, and I think that's a great question, and I think it may be for Megan, but I will just start and add something to the conversation. I have seen a study, unfortunately, it's not Nevada specific, that focuses in at least one component of the study from the National Health Law Program talks about who uses telehealth. It's again at a broader national level and not specific to Nevada, but I'm happy to share that resource and, you know, really call out some of these health equity issues. And I can say in our work with the Western Coast Compact, you know, in creating this framework for telehealth, that's been one of the key principles that we've been thinking about and trying to address is how do we ensure that any system that's developed or any of the changes that we propose to continue really don't exacerbate, but really help address creating a more equitable healthcare system. So I don't know that I have all the answers, but I will say that I think it's a great issue to highlight and something that's definitely on our radar and that we're thinking about.
And Teresa, I don't want to put our next speaker on the spot, but she might have an answer to that question. I know that CoMagin's been tracking telehealth policy, intended and unintended consequences in multiple states. So hang on to that question. Anything else for Suzanne? Looks like Flo has a question.
Yes, thank you. Just a quick question on, I understand, is the state planning to attempt to relax any of the requirements? I know some of them are federally based, but some of the ones that the state could relax, are they planning to, such as maybe the expansion of services that are allowed that weren't allowed under the statute, but have been allowed during this COVID-19 period?
Yes, so I think that that's what we're looking at in this telehealth framework is how can we continue to promote access to telehealth while also realizing, you know, that we have, as was mentioned previously, budgetary shortfalls, but in terms of just promoting access to care, we think this is a really critical piece of that. So we are exploring those options.
Mr. Chair, this is Sean Shaner. Can I ask one question?
Yes, absolutely, Sean.
Suzanne, thank you very much for the presentation. Just two questions actually really quick. One, for the benefit of the commission, if you don't mind, would you just be able to give a high level overview with respect to Medicaid and the partners that you work with in certain areas, whether that's urban or rural? I know some membership populations work with managed care organizations, others don't. And then with respect to current economic situations in the state and 28% unemployment rate, I imagine that you've probably seen some pretty large increases with respect to Medicaid enrollment over the last couple months. If you don't mind just touching on those two things really quick, just so we all know how it operates, at least at a 30,000 foot level, that'd be great.
Yeah, great question. And I apologize. I had intended to do this as part of my introduction, but I failed to do that. So really good question. Nevada Medicaid covers about 20%. I think now it may be up to closer to 22% of the state's population. And we do have two primary service delivery models. We use managed care in the urban counties, so Clark and Washoe, and serve about 70% of our overall population through managed care. There are a couple of populations, even in the urban counties, that are not currently in managed care, and that's primarily the age blind and disabled population. So that's kind of at a very high level, you know, serving about 20 to 22% of the overall state population, low-income Nevadans, and do have two primary service delivery models, managed care and fee-for-service, which is what we use in the rural and frontier counties. I do have data on our increases in enrollment. I don't want to misspeak, so if I could provide that document and follow up, it is somewhere on my table, but I don't have it handy, but I think it's been about a 7% increase over the last couple of months in enrollment, and I do know that we're now over 700,000, where and that's Medicaid and CHIP. Typically our Medicaid only had been about 645,000. I think in April and May it was around 670, 680. Again, would be happy to provide that information to the commission, and doing this from memory, which is always a little dangerous. So be happy to follow up with that information.
That'll work. Yeah, thank you. Other questions? All right, hearing none, I'd like to continue on with our next presenter, which is Trudy Bearden, who is a consultant to Comagine Health. Trudy, welcome.
Thank you. Let me get screen share going. Great. So Megan and Suzanne, really great presentations. Some of my content is going to overlap with what you presented, and when that is the case, I'm going to gloss over things just in the interest of time. For those of you who don't know who Comagine is, we are a nonprofit organization. We are the CMS designated quality improvement organization for Nevada and 5 other states, Idaho, Oregon, New Mexico, Utah, and Washington, although we have worked in almost all of the states at some point or another, and you may know us as Health Insight or Quality Health, which were our names before we merged. And we have been improving healthcare in our states and beyond for 45 years. As John mentioned, I am a senior consultant, but I'm also a clinician. I've worked in the inpatient setting, I've worked in the outpatient setting. I have been the clinical manager of a safety net clinic. And I spend most of my time as a senior consultant working at the front lines trying to improve healthcare service delivery. And when I saw telehealth as not a panacea, I absolutely agree. I think it was Teresa who said it's not a panacea, but it is a good modality for healthcare service delivery. And so we're going to go over a little bit some of those opportunities that were discussed by Megan and Suzanne, and think about, what are the ones that maybe we need to commit to a little bit more and which ones may be relaxed a little bit. And I agree, Nevada is progressive when it comes to telehealth. And it's really great to see that they are already ahead of the game and already have things in place that have, for most states, are new with the public health emergency. And I think it was Suzanne mentioned that remote patient monitoring is not covered by Medicaid. And this is one of the virtual services. It doesn't fall under telehealth, but it is a virtual service. And the evidence is incontrovertible that it decreases emergency department visits, admissions, and readmissions, and can be very potent for reducing per beneficiary costs. And unfortunately, also Medicare does not. So Medicare reimburses for remote patient monitoring, but not if you're an FQHC or an RHC. And those are actually the sites that need that type of payment parity, looking at things in a little bit of a different way. So are there perhaps virtual services for which we should have payment parity, even though the state of Nevada is pretty good about payment parity, notwithstanding our conversations thus far about it. Suzanne and Megan, just reflecting what they said, in Nevada, since 2015, insurers are prohibited from requiring an in-person visit to establish a relationship. And as you know, Medicare during the public health emergency lifted this one. You already have it in place. Additional consent, which is maybe a conversation for another day. For example, I live in Idaho, and if you are going to do consent for the Idaho Medicaid, it's really, really complicated and involved, and each state has their own requirements around consent. In the state of Washington, for example, you only need to get consent if it's a telepsych visit. So I'm not going to cover these because the rest of these bullets were already covered, and I'm just going to move us forward. But again, just making the case that you are progressive, you are ahead of the game, and it's really awesome to see. In your state and in my state, we have health professional shortage areas, which are now designated mostly as rural. But in my state and in Nevada, there are urban areas where we have health professional shortage areas. So it would be great if Medicare, state Medicaid can keep lifting those geographic constraints, because if I were a clinician still seeing patients, if I wanted to do telehealth for Medicare, I would have to go to a website to see whether I was in a HPSA designated area, and if not, and if I was a health center, it would be completely off the board, and it's a disservice to our patient population. Health centers and rural health clinics as distant sites, I have never quite understood why Medicare has limited these, they are like islands in these really rural areas where there may not be another option besides a rural health clinic or a health center for you to get care unless you're going to drive 4 or 5 hours. And so I have never really understood why CMS has limited the FQHCs or the RHCs. I think this is a big lift for it to stay in place, and that is Medicare would actually have to change the law to change FQHCs and RHCs as distant sites to deliver telehealth. The audio only interaction for telehealth services, audio and visual may be ideal, but it's not possible in some areas, as we know. And this is the piece that I think Teresa may have been alluding to, like what are some of the ways that it increases disparities? If you don't have internet service, if you don't have a tablet, if you don't have a laptop or a computer, prior to the public health emergency, you could not engage in telehealth services. Or if your data plan was not such that it could be supported. So I think it's reasonable to have some of the telehealth services be audio only in the state of Idaho, if it's an Idaho Medicaid telehealth visit, prior to the public health emergency, if the visual part was glitchy, the clinician was not actually able to even bill for that telehealth visit. And building on to that, it's unclear to me why CMS limits using your smartphone with audio and visual. They lifted that in the interim final rule. This should always be in place. And again, regarding disparities, if you don't have a data plan that can support an audio and visual for a telehealth visit, it only worsens disparities. I work with a lot of health centers, truly from coast to coast, and one of my California health centers, they actually purchase prepaid phones and are able to give them to some of their most vulnerable patients so that they can do telehealth, and they're doing it by audio only. But it is one of those, the way Medicare currently has the constraints around audio and visual, it really exacerbates disparities. In Nevada, the provider types are already expanded, so I'm not going to go over that first bullet point. The enhanced reimbursement for select services has been really important. So in 2019, Medicare started reimbursing for virtual check-ins, but it was a little bit measly. It was $14. However, Kaiser Permanente and Group Health both were doing virtual check-ins for free. Basically, they would look at their calendar, they would look at their schedule of who was coming in for the day, and if it was an easy visit, they would just convert it to a telephone call, and there was zero reimbursement, but it was the right thing to do. Say a patient was a mom, had a migraine and 3 kids. If her clinician called her and said, "Hey, Katie, I see you have a migraine," and ruled out red flags, like this is not like she's having an aneurysm or a stroke, and is able to call in the patient's migraine medication, Katie does not have to get herself out of bed, get her 3 kids in, drag herself into the clinic where it's a challenge to even park. And then in in 2019, Medicare started reimbursing $14, and I was so excited. And all the clinics that I work with, I'm like, oh my gosh, this is the best thing. And they were like, nah, it's only $14, not going to do it. So during the public health emergency, CMS has upped the reimbursement to closer to $24. And, you know, now when patients won't come in, if you are a clinician, you look at your panel of patients, look at your most vulnerable patients and use the virtual check-in, or let your patients know that they can utilize the check-ins. The patient home as an originating site, both Megan and Suzanne covered that. You know, that only makes sense. I was talking to a daughter who is the primary caregiver for her parents, and she says it's like a military operation to get her parents into the office. And she said, and they sometimes don't even touch my parents. You know, like, why did I drag them all the way in here? And anyone who's in the medical field will know that there's this oft quoted statistic of 80% of the information that we need, we get by talking to the patient. We get through the history of the present illness, and that's not always the case. Sometimes you really do need to do a physical exam, listen to heart, lungs, do range of motion or whatever. But having patients being able to be seen in their homes, seen, big air quotes, I think is really important to keep. Our hospitals billing for telehealth, this is also a means for capturing revenue for, so our critical access hospitals that are no longer solvent and are closing their doors. You know, if the hospitals can keep the larger range of services that they can bill for, this might be a way for them to at least capture some revenue. In the state of Nevada, this established first new patients is not such an issue. So, you know, I'm not sure that it warrants any further discussion. The other thing that Medicare has relaxed during the public health emergency is kind of allowing that incident to care, which happens in most practices. So we have team-based care. We want everybody working at the top of licensure. And with telehealth, most of my health centers are following exactly the same workflows, well, almost exactly the same workflows that they did with in-person visits. So the reception staff will call the patient, they'll get the demographics, they'll double check insurance. I think this is an opportunity to collect that data of who can engage with telehealth. So if during intake, wouldn't it be great if you could identify patient is able to engage in telehealth or not, and what functionalities do they have available? So you know what, this might be a new piece of demographics that we collect when we see patients. MAs and nurses still doing pre-visit planning, identifying and addressing gaps in care. It's, of course, it's a little more challenging with telehealth. Although I will say that even my practices that are working on improving their colorectal cancer screening rates, they talk to patients about colorectal cancer screening. They're mailing the fit cards, and my health centers are telling me that they actually have higher return rates. So people are stuck at home, so they're turning those around. So Nevada already has, you know, this cross state lines, which is good, but I heard earlier the concern that if we kind of allow all comers into our state, you know, is there going to be competition for our folks who are already living in the state? And we know other states are considering this, especially around telemental health. I got an email from a nurse practitioner who provides services at our nearby reservation, Fort Hall. And to get any patient in for behavioral health, it's a 3 to 4 month wait. Just breaks my heart. Yes, I hear you're anxious. I hear you're depressed. Yes, maybe you're suicidal, but just hold on to that. I'll get you in with somebody in 4 months. And so to expand that access, a lot of our states like Idaho and New Mexico come to mind. They are kind of opening up their options for telemental health. So, you know, that's what I always want to know. In any clinic, any area, any state that I am working in, what are the telemental services like? What is the current wait time? If you go to a health center versus you go to, you know, a private practice, what is the current wait time? How can telemental services be expanded to reduce that wait time? I think that we are going to see a mental health crisis from COVID-19. The Pew Charitable Trust has some really interesting data around the increased use since COVID-19 with anxiolytics or medications that reduce anxiety and depression diagnoses. I am concerned a little bit about quality assurance. So how do we make sure that each telehealth visit is equally excellent? So we talk about quality improvement, but quality assurance concerns me, especially when you have people who are out of state. You know, it's not like we can join a visit and see, you know, oh, did this work well? Did this not work well? How was the clinician's website manner? Was the patient helped? Did they get their needs met? So I am a little concerned about quality assurance with telehealth, and I'm not quite sure how to get around it. We work in, like I said, a lot of states. I work with a lot of practices in a lot of states, and one thing that is really, really hard and is increasing inequities is, and I don't want to stress the inequities piece, I truly believe that it is a great modality for those for whom it works. But arranging translation services for a telehealth visit can be extremely challenging. One of my colleagues lives in New York City, and the range, of course, is tremendous, but getting the timing right is really, really hard. So I don't recall who mentioned data, but data is really important. And at CoMention Health, we have an amazing team of data analysts. And as soon as COVID-19 hit, we went right to the data. We looked at the telehealth data across all of our states. It's delayed, and we have our fingers crossed because CMS keeps, since May 17th, CMS has been promising to get us more claims data. The data we are able to access in each of our states is different. So in Oregon, we can get access to all payer data. I don't think that's the case in Nevada. But we have seen that the behavioral health codes are used a lot. The originating site for the long-term and post-acute care facilities and for the rural health clinics is just terribly underused. And if you have been to or worked in a long-term and post-acute care facility or a nursing facility, you know that getting somebody who has functional deficits, who may be cognitively impaired and gets confused when you get them up and move them, transporting somebody to a primary care practice or a specialist can be very disruptive to both the resident and to staff. And so we really feel that telehealth might be a missed opportunity here. Idaho Medicaid has partnered with Dr. Doug Young, who is a champion of teledentistry. So I think there are some opportunities around telehealth that we miss. Every year, CMS comes out with the list of telehealth codes, and there were about 100 for 2020. It was greatly expanded, so we're close to 200 now. But I think when we think about telehealth, we think about telehealth versus an office visit. And telehealth actually covers so much more. I spoke to I think she was a certified diabetes educator who is providing diabetes self-management therapy and medical nutrition therapy in Montana. And she's doing it by telehealth because those are reimbursed and have been for many years, telehealth codes that are reimbursable. Advanced care planning is a telehealth service. Now, if never before, everybody should be doing advanced care planning, even those who maybe do not intubate or do not resuscitate. They might go, well, if I am diagnosed with COVID-19, I might take a ventilator after all. So I think there are a lot of opportunities that we may be missing or not thinking about. There are also, for example, I'm just going to skip that for now. So in the state, I think there are opportunities to rally and coordinate partners. So we are so pleased that Eileen Colin of CoMagin Health, we're so pleased that she is going to be pulling together the Nevada Telehealth Alliance. There are clearly resources are abounding. Suzanne, I was so impressed by all of the resources in your slides. That's amazing. Your Southwest Telehealth Resource Center is also another source. Applying for, knowing what the funding streams are, I get the sense that the feds are going to be pushing a lot of funding to the states, to the telehealth. We already know they're pushing money to the telehealth resource centers. Provide technical assistance. So practices don't know what they don't know. And I was talking to one of my health centers and I said, so what's the workflow for your telehealth? And they said, well, the receptionist calls the patient and says, are you ready? And then when the MA is free, the MA calls and does intake. And then when the MA is done with the intake, the clinician calls, and sometimes the patients don't answer. I'm like, okay, so, and the patients, from the patient standpoint, they're receiving 3 phone calls and their appointment may or may not happen. You know, they may have moved on to other things. It's kind of like when the cable guy calls you and says, I'll be there between 8 and 3 p.m. So they haven't thought about their workflows all the way through. They may not have the right templates. They may not. So I think technical assistance is going to be key, especially if you can get that funding. And just providing somebody with a resource doesn't always work the best. So, you know, clarify the telehealth perspective. So here at CoMagin Health, we believe telehealth is an effective modality that goes towards the triple aim of reducing per beneficiary cost, improving outcomes, and improving the patient experience. And we may extend it to the quadruple aim, which is also improving the work life of staff. And if you can do telehealth, especially if you can deliver telehealth while you're still at home because you may not be well or we have inclement weather, I think there are many ways for it to improve the work life of our staff. So it's not, I was talking to a physician the other day, she saw her PCP and her PCP apologized for doing telehealth as though it was substandard care. And she made the point, I don't know why he said that. Telehealth is not substandard care. It's another modality when the case is right. I am concerned about health inequality and telehealth equity, various groups of people. So if you are homeless, you know, that's very difficult. If you're an undocumented individual, etc. Do you have possession of means to engage in telehealth? If we say you have to have a device, you have to have connectivity, you have to have a data plan, like as we start checking those off, I feel as though our population that can engage in telehealth just starts shrinking and shrinking and shrinking. Data analysis, we have to go back to the data. It tells us the story and it lets us know about our opportunities to improve. When we looked at the data, the telehealth data, we saw one rural health clinic, I don't remember which state it was in, they billed the originating site fee, which is a tiny little reimbursement of about $26, but they were doing telehealth. And in 1 year, they were able to bill and bring in over $20,000. We have seen health centers that bill telehealth a little bit here, a little bit here, a little bit here. And then in 2019, or they just quit doing telehealth. Like that raises a question to me. We were able to see for virtual services, we were able to see the use of remote patient monitoring. And because we do echoes, we were going to do an echo session on a remote patient monitoring. We went to the data, we're like, who's billing remote patient monitoring? Let's go talk to them and get their lessons learned. So I think it's not just about telehealth services, it's also about virtual services. So interprofessional consultation services, there are 6 codes. One of them is for the clinician who is referring the patient. Here in where I live in Southeast Idaho, we have a shortage of neurologists. So at my PCP's office, they were telling me that they need to get answers more quickly. And so they use these codes and they talk to specialists and they're able to do consultations where the consultant is reimbursed and the referring physician is also reimbursed. The transitional care management is a virtual service, but it's also a reimbursed telehealth service. And I'm happy to go into those more, but I also don't want to bore you with unnecessary details. So all of the virtual services are really, really important for expanding access. Technology. So I know that in the Washington Healthcare Authority provides Zoom Health for all clinicians in the state of Wyoming. They also got grant funding to provide HIPAA compliant platforms. Practices get really confused with business associates agreements. So if you're going to have a telehealth platform, if they don't sign a business associates agreement with you, you want to run the other way. But how do they then update their security risk analysis, which is required by HIPAA, with all of the changes? Like, how do they write their policies and procedures for the technology as well? And I know that Health HIE Nevada and is working on a platform. I'm sure the rest of you on the call know far better than I, but I mean, this is an answer possibly for technology, affordable technology. I've heard some concerns about fraud and abuse. CMS is also worried about fraud and abuse with telehealth services. So what needs to be in place to monitor fraud and abuse? There are certain patterns that you can look for. CMS could tell you, but you know, then they're unwilling to share their audit protocols around everything from meaningful use / promoting interoperability to the quality payment program. But it is something to think about, like what are going to be the red flags for fraud and abuse. I'm actually only going to touch on this a little bit. So we've thought that employer and employee engagement was a great idea. We have since talked to our board members. We thought, wouldn't it be great if an employer would have a protected, safe spot for telehealth visits? And yeah, that might work for some organizations that have an office, but if you're a construction company and there isn't really technically an office that people go to work at, this may not be an option. I do think that employers can facilitate telehealth, and I think it would be reasonable to get the word out and possibly collect some data, possibly support them, and or provide some education. Community, so many opportunities to explore, and Eileen is our Director of Community Engagement. I'm sure she has a lot of things brewing in her noggin about our communities, but you know, could the YMCA or the library help with expanding telehealth services? So I'm going to end here. I have 2 sets of slides, and I will bet that they are only repeats of what we saw with Megan and Suzanne's slides. And that's all I have for today.
Trudy, thank you very much. Appreciate that presentation. Do any of the commissioners have any burning questions?
Nice job.
I want to be mindful of our time and know that Trudy is available to us going forward. And again, really appreciate that presentation. Hearing no questions, I would like to now turn to Dr. Rhodes from Southwest Medical Associates, and I turn the microphone over to you, Dr. Rhodes. I am not hearing him.
Dr. Rose, I can't hear you. I don't think anyone can hear you. Unless it's just me on my end.
No, I can't hear either.
Okay, you don't have, it doesn't seem like you're unmuted, and we can certainly see your video, but I think there might be a connectivity issue on your end in which your mic is not turned on the computer. If I can help you, at the very bottom of your left hand on the screen where it says like the mute button, if you want to press a little button to the right of it and it'll say select microphone, just make sure that the microphone is one of your devices. So it looks like it's just a microphone issue. That helps. It's a nice window.
Sorry about that. We'll see if this will.
Perfect.
Now, very good.
Did that work?
That works.
Mike, did you
Okay. I can barely hear you guys now, but we'll do our best. Does somebody have my slides that they can bring them up, or do you need me to share my screen?
You know what, let me go ahead and share. If you want to go ahead and speak, I will get up your slides so we don't delay in time.
Okay, thank you. Sorry about the mic issues. I'm not sure what's happening on my computer, but I plugged something else, actually my dictation microphone in, and it seemed to work. So again, thank you very much for having me today and getting to talk to the commission. I was asked to come and talk about some of our experience at Southwest Medical as we have significantly expanded our telemedicine, video medicine capabilities going into COVID and everything that has brought. So going into COVID, we started out with our telemedicine clinic known as the Now Clinic, doing virtual visits as really support for our urgent care and convenient care locations. It was something that's open 24 hours a day, 7 days a week, with the ability to do face-to-face video chats. And we've been doing it for over 7 years and having significant success with our patients who, once they get used to using the platform, really love the platform and being able to use it. Last fall, we'd made a decision to start rolling it out into some of our other service lines. We're working on bringing it into primary care and running some pilot programs there. So we had a couple of providers who had started to use this into their practice. And we're using it in some of our specialty areas, particularly in outreach, some of our rural clinics and rural patients that had a harder time coming in. So we're using it in our rheumatology and our cardiology before the entire pandemic started. Then with the pandemic occurring, we saw this as a need to roll out further, and we did add further services. Next slide. So having our own platform had a lot of advantages to it for us. You heard a lot of people talk today about some of the concerns as the emergency measures are removed, what will still be available. Having a HIPAA compliant platform for us to be able to use and roll out immediately, we found is a great advantage. We also, because we're using it, had technical support available, people who knew our system and knew how to help us in case of problems. We also had our EMR set up for video notes and compliance, which made it easier as we rolled this out to so many more providers. We also did create a system in our EMR. So when patients are available or able to use telemedicine, I heard somebody talk about that as demographics to be able to take in. We actually have a place in our EMR where we can take that information and know if they've set up to be using telemedicine, or if they want to get training to use telemedicine for future visits. Our call center also is familiar with the telemedicine platform and therefore knew how to help schedule patients into it as they'd done the pilot programs with our specialists and a few of our adult medicine providers. And then another advantage was our providers and staff that had used video health became our educators. Many of us in medicine are familiar with the phrase, see one, do one, teach one. And we used a similar analogy to educating our providers and our support staff and everyone around using the telemedicine platforms at Southwest Medical. Next slide, please. So we were quickly able to expand our services. As I said earlier, our rheumatology and cardiology programs, we're doing pilot programs in there, and we had just a few adult medicine. We were able to expand that out through all of our services as a fully integrated healthcare group. And all of the services listed on this particular slide are now providing video medicine or telehealth appointments with their patients. Next slide. So in adult medicine or primary care, which is where I practice, we were able to really expand the use of what we were using the virtual visits for. As someone had pointed out, and I would agree with them, this is not a panacea, but it really can be used for a lot of things in medicine. Our routine follow-ups many times can be done through the telemedicine, and some of the limits of using that in the past, as pointed out, was our ability to bill for those services. So having telemedicine for routine follow-up is good quality care and very appropriate for the patients. We've been able to use it for medication evaluations, reconciliations, and med refills where appropriate. Patients who have tests or imaging results that need to be reviewed more than just with a telephone call, we'll use telemedicine platform for that. We're using it a lot to manage our chronic conditions, and particularly our patients with multiple comorbid conditions. We're checking in on them on a regular basis with telemedicine connectivity, particularly during this COVID crisis, to make sure they have what they need, that they're safe at home, and they're receiving all their medications or follow-up or anything that may put them in harm's way. We can take care of minor illnesses. Obviously, our Now Clinic is a walk-in type of telemedicine clinic that does it. We've recently been able to add our annual wellness visits to what we're doing within our telemedicine platform, and actually are scheduling patients appropriately for those also. Next slide. So as we went into COVID, telemedicine became really critical for our ability to take care of our patients. Our goal, as the first couple of weeks of COVID came on, and we're hearing all the stories from other states, one of our sister companies in Seattle was sharing their experiences with us. We wanted to do everything we could to keep our patients safe and keep our clinics safe. So we were able to triage many of our patients through our telemedicine platform, and then be able to transfer them or have them referred to a curbside testing facility. Southwest Medical was the first to have curbside testing in the state of Nevada. We opened that on March 9th at 4 locations. So patients could come in, get tested, and then be followed up. So we use telemedicine to follow up those visits. And then we also, if someone was positive, was able to follow them with regular visits to check in and see how they're doing while they were sheltered at home. We also had the benefit, as our family practice residency program had already been trained in the video platform. And so they actually became active in supporting our Now Clinic as we see the exceptional spikes in visits over the first couple of weeks. Next slide. So this is an example of our Now Clinic and the spike in visits that occurred. And you can see we had significant spike coming in February and then into March, and that our wait times went up. So we had to add many more providers to be able to take care of these patients. We did this by taking some of our high-risk patient providers that weren't appropriate to be in the clinics and asking them to be on the telehealth platform. And then with the support from our family practice residents, when they were able to get that down. We've been able to get our wait times down to less than 10 minutes for our Now Clinic. And you can see that the visits continue to be up. And so we anticipate this being a long-term use in healthcare and another way that patients want to be able to access healthcare. Next slide. So, so video visits have really enhanced what we can do with our patients. We continue to see our high-risk patients while limiting their exposure by bringing them into the clinics so that we could arrange initially telephone, but now video visits when possible, check in on those patients on a regular basis, trying to keep them healthy, again, making sure that their needs are being met, that their follow-up is occurring, that they have their medications, without having to bring them in the clinic, bring them out of their home, add to their overall exposures. By doing this, we've also been able to limit our exposure to our clinics to keep our staff safe and available for those who really need us, because as most people on this call are more than aware, just because COVID was out there didn't mean all the other diseases weren't out there also. So the better we could manage those, the better we could keep our hospitals and urgent cares and ERs less packed, so that those who did have COVID-related illnesses would have access to care. We've also used this to reach out to our more fragile patients with multiple comorbidities to make sure they were safe and that their needs are being met, and been able to reduce their hospitalizations through that process. And as we were watching the stories unfold, we really saw our priority in the outpatient adult medicine world as to how do we keep our patients away from the hospital so the hospitals would be available for those who really needed it. Next slide. So our success stories from April 6th to May 31st, we've seen almost 10,000 video visits just in our adult medicine department. Our net promoter score and our patient satisfaction results have also gone up as patients really appreciated the ability to have access to us. And when they were seeing so many things were being shut down, the fact they knew their doctors and their health delivery organizations were available to them, that meant a lot to them. And particularly because we were proactively reaching out to patients to make sure they were okay, making sure that they had what they needed, that their medications were being refilled. We do anticipate video health being a continued part of the offering. And we feel because we have a HIPAA compliant platform and our EMR has been adapted to be able to collaborate with that we'll be able to continue this platform with minimal adaptations moving forward. We have also trained and provided experience to our future generation of providers through our family practice clinic, giving them great experience in telehealth, and for them to be able to see the importance of this platform. As many of you may be aware, most training of residents, with the exception of family medicine, occurs in hospitals where they get more limited exposure for this. We also have used our video health to do visits in our LTAC and skilled nursing facilities, where they can take in an iPad or similar tablet type of apparatus and do video visits with nursing staff there without having to bring the providers in, reducing continued exposure for our providers and reducing exposure into the LTAC and skilled nursing facility by bringing more people into them. And also, and someone talked about providers' satisfaction, for our high-risk providers who are kind of having just to go home and couldn't be in the clinic, being able to use the video platform and talk to their patients, see their patients, care for their patients, has really brought a sense of contributing to the team, contributing to healthcare, continuing to fan the flame of their passion for healthcare in their patients. Next slide, please. So just some more success stories. I feel our platform is going to be sustainable moving forward. More of our patients have signed up and able to use the Now Clinic platform, making it available for scheduled and drop-in visits. We've had excellent provider engagement, and it's helped, I believe, with our provider stress during this COVID pandemic. And we're also now using it to be able to stagger our visits within our clinics, which helps us balance out the flow in the clinics and ability to provide continued social distancing in the clinics. Next slide. As I said, how we've had a lot more patients sign up. We were averaging somewhere around 2,000 to almost 3,000 people signing up a month prior to this. And then you can see in the past 3 months, we've been at 9,200 and then 16,000, 13,000. And June was an early number, so that's probably not full as to how many we'll have sign up. But that doesn't mean they just had a visit. Those are people who are now on our telehealth platform, and we'll be able to use that both to do drop-in clinics with our Now Clinic or be able to contact one of their specialists or one of their primary care providers when appropriate for their health care be delivered that way. Next slide. So just to finish up with a few lessons learned, we found out it was not easy to provide 450 providers with all the equipment they needed during a pandemic when the whole world was converting over to WebEx and Zoom. Getting appropriate cameras was not easy. We used desktop computers, so we did not have laptops with cameras for all of our providers. So we've been able to set up workstations so that we can rotate through those stations as we got that equipment. We also learned don't prejudge a patient's ability to use technology. It's been very surprising. We've had 85-year-old patients who have just went into this and did great and got right on and loved being able to do it. And we've had young patients who you thought this would just be easy for them to do, and they had some struggles. So it's good to have your staff trained, the ability to walk patients through the signing on, help them figure out how to get onto the platform. In some of our clinics, we also have used Doximity once they had a HIPAA compliant platform as kind of our backup. So when we couldn't use that, that seemed to be a reasonable backup modality for the patients to be able to talk and fairly easy to use. We found the patients to be very, very thankful for having the providers available to them. We've also, and someone that talked about this early in your meeting today, found that you could get tremendous insight by doing a video visit because you're invited into the patient's home, and you don't get that insight many times when you have 15 minutes with a patient in a sterile exam room. You can see if there's clutter in the house, you can see what the lighting is, you can ask them to walk over and show you what's in their medicine cabinet. There's a lot of different things available through a video visit that you just can't get when they come in. And finally, we just found that many of our seniors connecting with their providers was a few social contacts that they had since COVID started, as many have almost been locked in by themselves, sometimes by family, meaning to do right, but just really socially isolating them from what they need. So the ability for them to talk to a provider or actually see their provider's face has meant an awful lot to them and their health care. So that's really our little bit of a story as we've gone into this and some of the success that we've had taking a platform that we already had and being able to move forward with it. And I know your meeting's been long, but I'm happy to take questions if there are any.
Quick questions.
Yeah, this is Dr. Khan, Dr. Oates. Thanks for that excellent presentation. It was certainly very educational, even for me. I thought I knew a lot about it, but I didn't know a lot about it. Having said that, you've had probably the largest experience of telemedicine, given the staggering numbers you just displayed. Help me understand, if you would please, a telemedicine visit versus a telephonic conversation with the patient. From a practical point of view, to a layperson, it seems like a difference of night and day. What is your thought on it, and how involved it is to do telemedicine versus in-person visit?
So I'm having a little bit of hard time hearing everybody else now that you can hear me because of the way my technology is set up. But I think you're asking what are the limitations between in-face telemedicine versus a telephone visit. And so I love face-to-face visits, and that full communication, seeing that full person is important. The telemedicine does allow us to see things about that patient in their home that we may not be able to see normally about that patient, as I threw out. A telephone visit's a good way to check in. It's hard to deliver really good, consistent health care on a telephone visit that's my personal opinion. Communication is so much more than just by words. And so I think you lose a lot when it's just a straight telephone visit. With the video visit, we also can make some assumptions. You can look at a rash. You can check a diabetic's feet and make sure that there are no sores on it. You can actually kind of get an idea if they're able to ambulate. You could even have somebody else hold the phone or camera and watch them as they do some things. They can point to where something hurts on an exam. So you can get a lot from a telemedicine visit or video visit that you won't get from a telephone-based visit.
All right, thank you.
Thank you.
Other questions?
Mr. Chair?
Yeah, Babette, go ahead.
Can you hear me okay? Okay. I have one question. I'll try to yell. I'm so sorry. Your presentation was
That's
really
okay.
helpful.
I'm leaning in, so you're spicing like my face right in your face as I'm trying to hear you.
I bet that helps on telehealth visits too. I bet that happens. So my question is, how we talked earlier about reimbursement. Are you guys reimbursed the same for the telehealth visit as you are if you do the office visit?
So we are, and not all of our care, but a lot of our care is value-based care. So that for us, reaching out to our patients, keeping them healthy, making sure we're doing everything we can and being proactive in their care is of great benefit. We're currently not charging any copays for our telehealth or video visits on any of our patients, but we've just felt reaching out to our empanelment of patients, being able to be proactive and take care of them ahead of time in the long run for the way we do things in a value-based system really makes sense.
This is really helpful. Thank you.
Okay. Moving quickly here, but seeing no other questions, I'd like to thank Dr. Rhodes and turn to our next presenter, which I believe is Bill Welch.
So thank you very much for having me.
Thank you. Bill, I believe you're on mute.
Yes, sorry, John. Thank you for the opportunity. I was asked to come and give a presentation on our broadband telemedicine initiative, which we initiated back in 2009. You've heard a lot about telemedicine, so I'm not going to speak specifically to telemedicine, but I will tell you that it takes significant broadband, internet, telephone capacity to facilitate telemedicine. I used to be, and I won't say how long ago it was, but many, many years ago, I used to be a hospital CEO out in Elko, and we used telemedicine for teleradiology. And it became more and more difficult to have enough capacity to transmit the procedures to a radiologist located in an urban community. At that time, we had many specialists that came out to rural Nevada, cardiologists, ENT, psychiatrists, and others. But as our shortage continued to get worse, as the economics changed, fewer and fewer specialists were willing or able to come out to rural Nevada. And so we became dependent upon telemedicine beyond just teleradiology, and we started looking at ways to be able to expand our capabilities. That and other issues brought us to a point in time where we were made aware of a grant through the U.S. Department of Commerce America Recovery and Reinvestment Act, also known as the Broadband Technology Opportunity Program. They made these Broadband Telemedicine Initiative grants available. We submitted a grant in 2009, and we were fortunate to be a recipient of a $19.6 million grant. We did have to put up a 10% match, but we expected that we were going to be able to build a fairly comprehensive broadband fiber-driven system throughout the state of Nevada for $25 million. I'm going to talk about that in a few minutes. We soon learned otherwise. Initially, the broadband grant was to connect all of our hospitals, number one priority. Second priority was to connect other healthcare providers in our communities, then local nonprofit organizations, government agencies, etc. But I'll explain as things changed. But our primary goal was to ensure that we had telemedicine for rural Nevada to meet the citizens' needs. Next slide. We did complete the grant in 2017, and it was a long 7 years in getting the project completed. Some of the things that I think need to be understood is that we learned a lot about telemedicine today, but there are various modems for which it has to be transmitted. A lot of it can be done by telephones. It could be done by telephone lines. It can be done by internet, but all those takes a certain amount of technology. Nevada was dependent upon copper lines throughout much of rural Nevada, and it took, I won't go into a lot of details, but it took a lot of copper lines pulled together to provide enough capacity to transmit a telemedicine function. We also had a lot of satellite service out in rural Nevada, even in urban Nevada. It still have a fair amount today, but satellite is point to point. So as you're going across the state of Nevada, you had to have a lot of satellites out there to be able to get connectivity. Finally, there was fiber that was available from getting from Las Vegas to Reno, Nevada, but you had to go into California, up along California, then come back into Reno, or you'd go into Las Vegas, or excuse me, into Arizona through Utah, and then back over to Reno. For those of us who've been around for a while, we can remember back in the day when a meeting was scheduled on broadband or through compressed video, you were given a very specific amount of time to complete that program, and it was very slow motion. So your hand would be moving like this, and it was rather difficult. Those were some of the challenges that we were trying to resolve. Through this effort, we partnered with a lot of different individuals, and we would not have been able to accomplish this without these individuals, and I want to recognize them. First, the University of Nevada System of Higher Education, Nevada Division of Transportation, Nevada Energy, and Valley Electric. Ultimately, Switch became our partner, and about 2015, and with their help, we were able to actually bring the project to completion. However, you can see on this slide, the cost was a lot greater than what we had anticipated, and we accomplished a lot less than what we had hoped to be able to accomplish. Total cost was in excess of $40 million. Next slide. Simply, this is what we were trying to accomplish, and it looks pretty simple. We were going to build fiber from Reno across the state to Elko, and there was fiber out there, and the next map will show you a little bit of the challenges. Also fiber from Carson City out to Ely, and then fiber from Reno to Las Vegas so that it would all be within the state. The challenges that we had in doing this is we could not build duplicates infrastructure. So if there was infrastructure there, we had to negotiate and work with those entities so that we were not duplicating infrastructure. The other thing that we had to work at was going through the areas that we wanted to go through. We had to go through a lot of Native American reservation land. And so we had to, there was a lot of time spent on negotiating right-of-ways to make sure that we did not disrupt their land, but was able to get the fiber across their territory to make connectivity where we needed to. Next slide. This gives you a little bit better idea of all the different pieces that we pulled together. Going across Interstate 80, you had fiber by the Nevada System of Higher Education, but it could only be used for education. So we had to work through a negotiation so that we could get access to that for the hospitals and some of the educational institutions out in rural Nevada on 80. What we ended up doing there is the highway was built, but there was not a lot of exits to get off of. And the exits were limited in their capacity. So what we went through on that side of the project is we didn't put fiber across the state, but what we did is expanded the electronics, and then we would build out the last mile from their main line to the hospital facility, and then occasionally they would build off from there to the local school and or community college. Similarly, on Highway 50, across from Carson to Ely, there was fiber capabilities, but again, the electronics were very poor, and so we had to go across that line and change all the electronics so that we could get the capacity that we needed. Coming from Reno to Las Vegas, there were stretches where there was no fiber. And so we had to actually put the infrastructure, make the fiber connectivity. Then there were other areas where there were poles, but there were no fiber for broadband transmission. And so we negotiated with the various companies to get access to their poles so that we could hang our fiber. If there were no poles, then we were required to go underground to get the fiber in there. And you can see that there was actually sections between Tonopah and Pahrump, and then also from Pahrump into Las Vegas that we actually had to go underground with fiber. Next slide. So what did we accomplish? We did accomplish getting the good connectivity for the fiber with the Department of Education system. And then also through NDOT, we were able to get good connection across the state. And we did build with collaboration with our partners, getting from Reno to Las Vegas so that we do have in-state fiber connectivity between the state, the north and the south in Nevada. What we did not accomplish, and I think this is what's most important, next slide. While we had hoped again to be able to have enough resources, and we really felt that $25 million would have done that, but when you're paying for right-of-ways and then you find out what the cost is for building the infrastructure, you soon learn that $25 million is not very much in the fiber optic world. We did not build out to the community health centers. We did not have the resources to build out to the rural health center. We did not have the capacity to build out to physicians' offices. And those are all still issues today. Now, what we were able to accomplish to help offset this a little bit is off of the fiber lines, you can build towers to boost satellite capacity. And so it did improve some capacity out through those parts of the state where our fiber was, but really not sufficient to have meaningful telemedicine. There's various ranges of telemedicine capacity. For primary care, you can do a lot of that across the internet or the telephone lines. But when you're getting into the more comprehensive clinical diagnostic evaluations, you really need broadband fiber to make that as clinically appropriate for the physicians to be able to do their interpretations and studies. With that, the last slide, I was going to go into some of the challenges at the federal and the state, but there's been a lot of discussion on that today. What I'll do, Mr. Chairman, is for the record, I would like to submit something in writing. I don't want to belabor the points that have already been discussed, but I would emphasize, I think Bobette Bond mentioned it a couple initially, and then a couple of others. The waivers, once they go away, please know that they do not just impact Medicaid. They will also impact Medicare. They will impact the commercial carriers, and to the extent that even the self-funded plans are utilizing it, it will impact all of those. So that is something that we all need to be very cognizant of, and we should be working together to send our message to our congressional delegation that we need to have that resolved. There are a few things in the state of Nevada that we look forward to working with everybody in the 81 legislative session where we might be able to enhance some of our laws, even though I do want to acknowledge some of the comments that were made. Nevada has done overall a very good job in its laws in the state. And with that, Mr. Chair, I'm happy to answer any questions.
Thank you, Bill. I don't want to get ahead of myself, but that kind of recommendation is something that could come from the commission, and please do not let me forget that possibility. I think time is of the essence on getting those the PHE extended. So any questions for Bill? Thank you, Bill, and thanks for hanging on this long on this meeting. Joan.
Thank you. Nice to speak with all of you again. I'd just like to tell you a little bit about how telemedicine rolled out pre-COVID in rural Nevada, the issues we were having, and then post-COVID, what we've seen. So pre-COVID, as you heard, the patient, the originating site had to either be in a hospital or clinic. It couldn't be in the patient's home. The distant site could not be provided by a rural clinician. So all of our telemedicine was provided by specialists. We had great success with telestroke. We had great success with tele-ER visits. A lot of the hospitals who have intensive care use intensivists to take care of their patients telemedically. And in an outpatient setting, we had specialty visits. The issues that we saw were the Nevada licensure issue. On the eastern side of the state, a lot of the specialists from the University of Utah wanted to be providers in Ely. They'd been at the University of Utah for 25 years, didn't have any licensure issues, but it took, for some reason, over a year to get them licensed in Nevada. So that was a real barrier for us. There's also the issue of those providers, those specialists, making sure that they are credentialed with the insurance that's in the region so that we don't have those patients seeing a specialist who isn't in plan. And we recognize that early on as an issue. And with limited specialists or limited providers, that became a bigger and bigger issue. Also for the providers providing telemedicine, we found that it was very important that they understand the rural hospital's ability. What was in their formulary, what kind of diagnostics could we provide on site, and what were send outs. That became an issue that if physicians didn't understand that, there was a bit of tenseness. Also the platform, as you heard Dr. Rhodes talk, they use a special platform. Everybody wants their special platform. There's a lot of telemedicine platforms, and each specialist or each provider likes the platform that they can access their EHR through, that they're comfortable with, that they know. And so rurals were finding themselves with closets full of carts because everybody had a different platform that they used. And as Murphy's Law has it, especially in the ER, it was the nurse that always grabbed the wrong cart. We had them labeled, we had them named, but it seemed like we'd get to the patient with a wrong cart. The doctors also have special peripherals they like, and there's different peripherals. They don't all go to the same machine, and so keeping track of those. But when they worked, it was amazing. You could do ultrasound, you could do heart and lung sounds, the docs could hear it at the other end. It really is a lifesaver for rural hospitals and rural patients. The reimbursement, and to one thing, I think, Bobette, to a question you had asked, what effort does it take? Every provider needs a presenter when you're offering this in the hospital. And so we had to have several nurses or medical assistants trained with each provider to present the patient in the manner that they were comfortable with and that knew how to use the peripherals. The reimbursement for the originating site, so where the patient is either in the hospital or in our clinic, through Medicare and Medicaid for this type of pre-COVID care was about $25 for the rural hospital. And the distant site, Medicare and Medicaid paid as if it was in person, and the providers negotiated with the private insurances. So while it was wonderful, we advocated for this. It certainly saved lives and increased the access to care. It wasn't without bumps. There are hoops to jump through. In behavioral health crisis, we've used a platform called VC for both youth and adults, and it has been phenomenal. We the rural hospitals, use the Division of Public and Behavioral Health licensed clinical social workers for patients brought in on a mental health crisis, and it has been absolutely amazing. So that system works wonderful. Post-COVID, we've seen the increase in platforms that you can utilize. As you've heard, it can be FaceTime, it can be DoxyMe. There's all sorts of very simple platforms for providers, so it didn't include a lot of cost. The waivers allowed the rural site, the physicians in a rural site, to be a distant site. So that was a great advantage to patients, because their own doctor could see them telemedically and be reimbursed for that. What we found, and also in the waivers, the home could be the originating site where the patient was. So that was beneficial. What we found were technologically unable patients, patients who had flip phones, who didn't have iPads, who didn't have laptops, or if they did, they couldn't use them or connect. But we also found more sad to us was lack of bandwidth. Right outside town in Hawthorne. Hawthorne has great bandwidth at the hospital. You go 2 blocks and there is none. We found that with our community paramedicine program, where we had remote monitoring, and we bought hotspots, we bought everything we could. That didn't help. And there's areas like that all scattered throughout rural Nevada. If you're 2 blocks away from the hospital or a school, and you can't afford Wi-Fi, to the inequity questions that were talked about earlier, that is a disparity for those patients. It's sad. And in this time, when you don't want to bring the patient to the hospital, or the patient's fearful to come to the hospital or the clinic, being able to see the patients in their home is so very beneficial. So that technology literacy and the bandwidth issues right now are the biggest issues we've found in rural Nevada. As I said, many of these patients have flip phones, so the doctors have used just telephonic communications with their patients. Again, the other issue just with the bandwidth is the remote monitoring. There's such great capabilities out there and such great availabilities, but without adequate Wi-Fi or bandwidth, it is of no use for those patients. There is a bill in the House right now. It's called Helping Ensure Access to Local Telehealth, or the Health HEALTH Act of 2020, which would tackle many of these barriers that we're talking about. It was presented by Representative Thompson, a Republican from Pennsylvania, and Representative Butterfield, a Democrat from North Carolina. So the National Rural Health Association is backing this. We're very, we are sending letters of support, and we would think that all of Nevada would like to do that. And I'd answer any questions. I'm sorry I went through that rapidly, so you didn't have to listen to me continue to blabber.
Any questions for Joan? Thank you, Joan. Appreciate you staying on so long. Speaking of bandwidth, I think I am testing the bandwidth of my fellow commissioners with a meeting that I had not originally planned on going this long. I would like to push forward, not overly quickly or miss anything, but move through our next 3 agenda items unless I hear any objections. I know Sarah has a brief update under agenda item 8 on groups that we are collaborating or working with. Sarah.
Oh, thank you, Mr. Chairman. Members of the commission, I know we've heard a lot of really great information today, and you've all elicited more with your questions, and I'm sure you are all more eager to discuss potential policy recommendations and bill draft requests. So in the interest of time, I'm just going to take a moment to highlight a couple of items. What I'd like to bring to your attention that relates to your telehealth discussions is the Clark Regional, Regional Behavioral Health Policy Board. It's been brought to my attention that they did indeed make a action to request or use their one BDR to require insurance companies to indefinitely allow telehealth for psychotherapy sessions. So I wanted you all to be aware of that, know that that was happening if it is your desire when you are considering policy recommendations or potential bill draft requests to keep that in mind so we can consider any duplication of efforts. I'm not sure if that is the will of this commission at this point, but I wanted to bring that to your attention. The other thing I wanted to bring to your attention is our legislative committee on health care. Also, keeping in mind with duplication of efforts, I wanted you to be aware that they did have a meeting last week in which they heard a couple of presentations. Two came to my attention that I thought might fit within the jurisdiction of this commission's new focus, and it's related to access to care. One of them was a discussion about an all-payer claims database that did take place at that committee. And again, if that is something that is an interest into this commission, I wanted you to be aware of it for consideration and make sure that we continue to collaborate our efforts. The Committee on Healthcare anticipates meeting again in July on the 23rd, and then in August, I believe it's August 19th is when they anticipate having a work session. So just keep that timeline in your mind. Again, if it is something that you want to consider, let's just be mindful of their work and continue to collaborate and coordinate with them. The other item that I wanted to bring to your attention, and actually, Mr. Chairman, you may want to speak about this, was improving access to care through health workforce data collection, in which that was your presentation. So I wanted to just make sure that the commission was formally aware of those items. But again, I won't take too much time because I think that you all are eager to move on to the next agenda item in which you can discuss these potential policy recommendations and bill draft requests. So I can pause there unless, Mr. Chairman, you want to speak about your presentation, or commissioners, if you have any questions for me. Mr. Chairman, there you are.
I will speak at another time about that in the interest of time.
Okay, great.
Thank
Well,
you.
that's all that I have under that agenda item, unless anyone else has some questions.
Well, Sarah, it's
I don't
Bobette.
have a question. Oh.
Go ahead.
How about Bobette and Flo?
I was going to say, Sarah, could you just, the items that you just suggested for possible action, can you just add them to this list where we're supposed to be providing you with others? And so we've got this growing list that I understand the chairman somehow has to manage in a separate stream until we can get to it all, but at least not to lose them, because they both seem like they're worthy of everything you did today to at least talk through.
Thank you, Commissioner Bond. You know, that is something that you can talk about in the next agenda item for an actionable item. And I hope that you all do consider talking about this. And then it's a part of the work plan right now in the form of a general topic. And as you've seen in my internal memos to you all, what has not been established yet, and again, I guess we're kind of moving into the next agenda item, is policy recommendations and potential bill draft requests, in which we do not have any on there right now.
All right, thank you, Sarah. I'm going to move on to agenda item 9 and kind of partly to answer. Oh, I'm sorry, Flo had a question. Forgive me. Sorry about that.
Oh, I apologize. I don't have a question, but I do have to drop off at this point in time. I apologize. I thought we were going to be done earlier, and so I have another call I have to jump onto. So
we'll catch up with you later.
Yeah, I'll just follow up. Thank you.
All right.
Thank you.
Thank you. All right, moving on to agenda item 9 quickly. Sarah did mention sharing with you what we're calling a work plan, and it's really an earnest effort on our part to try to make sure that we are putting together as much a radar screen as it is a work plan at this particular point in time. And the policy issues or items that were listed on there are ones that have come up in our first June meeting, as well as emails that we've received from various commissioners. It's not intended to be an exhaustive list of all possible things we can entertain as a commission, but it is an attempt, as you communicated to us, to prioritize what needs to at least, again, be front and center of this commission, given the fact that we have a limited number of meetings between now and Labor Day. For the public, I will just mention that those items include, but are not limited to, COVID-19 incidence, prevalence, deaths by race and ethnicity, SES status, local and state public health services, access to and sustained funding for mental and behavioral health services, state budgetary constraints, sustaining testing, contact tracing, and treatment capacity, occupational health issues, not just for those attempting to return to work in the private sector, but also healthcare workers and their health and safety, access and insurance coverage issues revealed by COVID-19, network adequacy issues revealed by COVID-19, access to care through telehealth, which we've discussed exhaustively today, and then, as Sarah mentioned, data collection to inform health workforce policy. Now, if it is the Commission's desire, we can add to that list, but the issues that I highlighted there and that are again contained in that document that Sarah sent to you earlier this week, or earlier today, I believe, are items that, again, that you've raised and that you'd like to keep front and center. So as we think about this item, I don't know that we necessarily want to discuss potential bill draft requests. I have in mind a work session towards the end of the summer where we would hammer out some of those specifics, but I did want to just get a sense from the commission what we're ready to discuss or push a little bit further with respect to policy. As I mentioned earlier, and in response to Bill Welch's suggestion, I would just want to keep reminding that the commission is more than coming up with 3 bill drafts by the end of August. If it is this group's desire to pen a letter to our congressional delegation urging an extension of telehealth waivers, whatever it may be, again, I think that that's within our purview. And so with that, I don't know if the commissioners have any comments or suggestions for the good of the group.
Chairman Packham?
Yes.
Regarding the letter, I can't remember the bill that was just mentioned by Joe, but would that be something that we could support and asking our Nevada delegation to support either through co-sponsorship or other means?
Yes, and I'll ask Joan to give me more information on that, and that is something I could push out to the group for consideration. I'd like to just learn a little bit more about that bill.
Okay. Yeah, would you send the bill around, because it'd be good to actually have access to what's on it.
Yeah.
Chairman Packham, I think the issue about supporting keeping the HIPAA-related relaxation rules in force, along with some of these other things that have helped telehealth move forward, I think that doesn't, I don't know if there's a specific bill needed for that, or if there is a specific bill moving for that, but we could write a letter about that to our delegation for sure, right? That could be on our list.
Okay. I'm going to propose again, in the interest of time, that Sarah and I work on drafting actually 2 separate documents, one with what Bill suggested, and then the latter, which we all agree that we need more information on. And we can do that through communication to you directly via email.
Perfect.
Sure, Commissioner,
Yep.
Chairman, I can need to withhold any actionable item until the next meeting, unless it's a desire for you to take action now with the thought of creating that letter in the future. But if it is the will of this commission to draft a letter of support for an actionable item, that would need to take place at this meeting, or it would be, we would wait until the following next meeting in order to take action. I do not have the ability to solicit, the action via email to this commission outside of this meeting.
So this is Dr. Khan. So in reference to the letter to the congressional delegation, should we not get it right now? You can circulate the draft if we agree as an action to actually send a letter, then the draft can be circulated. That will become the action if everybody agrees.
Is our DAG still on? I presume that that's.
Let's have our DAG weigh in on that. I think that I'm not sure if I'm comfortable understanding that correctly. Greg, are you able to join us and provide your thoughts? Let me just check this.
Well, okay. I think in the
On as attendee.
okay, I think in the interest of time, that we could, he's on now?
You should be able to. Greg, are you there?
I'm here. Thank you for that, Sarah.
Yep, no problem. Thanks.
Yeah, I'm sorry. Can you just restate the question one more time?
Dr. Khan?
My question is, excuse me, if the commissioners agree that we need to send a letter to the congressional delegation regarding the subjects we have already discussed, can we agree on the fact to send a letter for that particular reason that we just talked about earlier? And the draft could later be circulated by Sarah to sign off on it.
Yeah, so what I would normally recommend in that instance is, so that you're not approving the draft outside of a meeting, because that starts to look like a vote, is you would just authorize a single member, usually the chair, to write a letter on the committee's behalf, and then he would just send it once he is satisfied with it. Because if you have that sort of individual sign off outside of a meeting, that starts to look like a vote outside of a public meeting, which would be create problems.
Okay.
But you're perfectly within right to authorize the chair to do it.
I'm fine with that.
That sounds good to me, but I will be soliciting everyone's input. Could I have a motion?
So moved, Dr. Khan.
Second.
Can I just, we're going to discuss, right, after the
Yes.
motion?
Yes.
So,
I have a second. Any discussion, Bobette?
can you just make sure that, I just want to make sure I understand. It's about the things that Bill Welch said that we should convey to the congressional delegation. It's not about this bill from Joan that we haven't read yet, right?
Correct.
Okay, I am great. Thanks.
Any other discussion? All in favor to that motion, please say aye.
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 Aye. Any opposed? Okay, hearing none, the motion has passed. I would like to continue on with the future agenda items and meeting dates. I am hoping at this point everyone has every other Monday marked off in their calendar, including our next meeting date of July 6th. And wanted to open it up for a brief discussion of what you would like to see on our next agenda.
Yeah, this is Jessica Flood. Can everyone hear me?
I can hear you, Jessica.
Okay, fantastic. So I know that all the commissioners are really wanting to work hard, and I think we're doing a bit of trial and error and trying to figure out how to do some deep dive work and being able to really suss out these issues. I was wondering if I could put out for the committee's consideration having two subcommittees that would meet. Basically, one would be to look at legislative bill drafts, and the other would be to work on recommendations for that letter to the governor. And so, you know, that would be in conjunction with the two standing items right now. So you'd have the commissioners, you know, suggest either BDRs or recommendations, and then those two subcommittees could go in and flesh it out further. And I thought that this was kind of the function of this even was represented in what Dr. Khan was just saying. It'd be nice to be able to get an idea and then have some time to really work on it, and then report back to the commission regarding, you know, if it is a good idea, what other states have done, or if other action would be recommended. So I just thought I'd throw that out to the commission and see if people would be interested in that.
Any response to Jessica? I think I've discussed, and everybody knows my position on subcommittees at this particular point, but so I have some hesitation about that proposal, but I did want to give Jessica the opportunity to put that out there, because I think the amount of time that we need to go through these issues highlighted by today's meeting that's gone a bit longer than I had planned just underscores what we have to do in a small amount of time. I don't know if anybody had anything additional to add to what Jessica had said.
This is Dr. Khan. So my views are similar to your views, Mr. Chairman, that since we have all dedicated the extra time and in a compressed fashion, if individual meetings that are scheduled ahead of time go an hour longer, but we are collectively coming to decisions rather than have subcommittees and then subcommittees deliberating and then it's coming back to us and we agreeing or disagreeing and going back for further assessment, evaluation, coming back to us. My thought is just let's move ahead, and if we can sacrifice a little extra time in each meeting, personally, I'm ready for that.
Okay.
Chairman, this is Howard Barron. Also, another point about the breaking up into subcommittees is not that we couldn't use the shorter, the additional deliberative time, but then there becomes an issue with public meeting laws and things like that, and having a quorum to be able to, you know, advance things. And so, you know, for example, today's discussion, we had a plethora of good information on telehealth, but really very little or no time to deliberate as a body about it. So in that sense, breaking up into smaller groups and talking about it makes a lot of sense. However, then we're just adding, you know, more time to our schedule, and it's probably going to become somewhat prohibitive.
Okay.
Chairman, this
Yes.
is Terry Bohannon for the record. I'm just curious, I mean, are we going to have several more of these type of meetings where there's significant presentations that are very useful and informative, or do you anticipate there being sort of a cutoff where then we do a little bit more deliberation and developing policy recommendations? I guess I'm just trying to see the big picture here from your standpoint.
I'm going to slightly dodge that by saying I will do what you tell me as commissioners you want to see and hear at these meetings. But I do think that what I anticipate us having is at least one, possibly two meetings on the order of what the interim health committee does. And that's they typically devote their last meeting to a work session only, in which they they have that deliberative discussion that you're referring to. I think we'd have to have to be somewhat narrow in what we put on the menu for that discussion. But that's, I see a work session or two towards the very end of the summer is how that would happen.
With that said, Chairman, is it possible that we make a very concerted effort in the coming meetings to hear from patients, specifically patients who have experience through the pandemic?
Yes, I think we heard that loud and clear today.
So this, Dr. Khan, if I may suggest that the presentations that we are requesting perhaps be time limited so that things move along, because some presentations can really become long. If the gist of the presentation can be summarized in a shorter period of time, if we mandate that, then that would be very helpful.
Duly noted. I will strive to do that going forward.
Chairman Packham, can I also ask a question, thinking about this from kind of a 30,000-foot view? We hear a lot about the term, vulnerable populations, at-risk populations. I thought there was a really interesting segment in one of the presentations about how there was a lot of outreach to fragile populations to make sure that all their needs were taken care of. And I am just thinking, for the purpose of our group, that we really define what we mean by vulnerable populations. I don't know if through the work that Caleb's doing, if they have done that, but I think it would be very important that we understand who those populations are so that we can really target the limited resources that we have to reduce hospitalizations and deaths in those particular communities. I know I shared with Sarah the MMWR from the CDC of who they've identified as those that were most at risk for hospitalization and death. So I would just suggest that we think about something similar.
Noted. And I think the CoMagin presentation underscored that as you start identifying those vulnerable populations, those are the segments of society that are also experiencing the most difficulty taking advantage of telehealth opportunities. So,
well, Chairman Packham, I would add to that idea, though. One of the things we started with today is if it's particularly COVID focused, we've got workforces that are more at risk for COVID exposure in Nevada than other populations. And I know that we're not OSHA. So how do we make sure that we're anticipating what's different about COVID than other infectious diseases in the workplace? Because I think Nevada is going to be a real test case for what happens with what the entire restaurant, gaming, hotel industry does with how to stay alive as a resort industry and be safe. So I'm not exactly sure what I'm asking for, but I do think if we're going to talk about vulnerable populations regarding COVID, it's not just who can get care, it's who's at risk for exposure.
Okay.
I totally agree. I mean, there was a restaurant that was just shut down in the Bellagio, correct? So I think absolutely, I envision some sort of, guidance for that, occupational, based on health. I mean, all age, race and demographic. I think there's a lot of things that go into this, and specifically COVID. We're going to have limited resources, and so those resources need to be targeted in an effective way, either through outreach and how do we get to those populations to help them understand what their risk is and how they can reduce it, but then also broadly, generally, how do we inform the entire everybody in Nevada how they are part of this entire equation and how what their actions are impact everybody else's actions.
Not to mention our 40 million tourists wandering in and out.
Oh, yeah. So in the interest of giving Sarah and I just a little direction for our July 6th meeting, I'm hearing some attention or discussion of patient perspectives, particularly vulnerable populations in the state. And I think what I have in mind with that would be not only probability of testing positive or ill health, but also the return to work issues, which fall disproportionately on low income people in this state. I would like to really press this group over between now and Friday to send speaker suggestions to Sarah and I. Your comments about the length of this meeting are duly noted, and I will press all my speakers going forward to be, that's not to slight any speaker. These were excellent presentations today that exceeded my expectations. But being mindful of your time and the work we need to get done over the course of the summer, please send those suggestions to Sarah and I. Do we have enough to?
John?
Yeah.
I just had, since we're talking about vulnerable populations, I would love a presentation on behavioral health in vulnerable populations. Like I noted, the behavioral health crisis. I think Dr. Stephanie Woodard could really do a great presentation, especially on Crisis Now and how we can support that.
Okay. So Sarah, I think we have enough to get the ball rolling on our next agenda. And again, please send those suggestions to both Sarah and I, and we will start drafting an agenda as early as tomorrow. Please continue to send your suggestions on how we can have a more streamlined meeting as well. I'm open to any and all suggestions in beginning student evaluations for 30 years. So I have a tough hide at this particular point in my career. Whatever we can do to improve that. Any other discussion under agenda item 10? Okay. Hearing none, I would like to see, Sarah, if there is any additional public comment, or Leslie.
Okay, thank you, Mr. Chairman. It looks like we have Vivian Leal. I'm going to unmute you momentarily and allow you to speak during public comment. One moment.
Hello. Are we ready?
Yes,
we are ready.
Okay, thank you so much for your determination, and the length of this meeting is great. So I'll be very.
Vivian, you just muted yourself.
Okay, can you hear me now?
Yes, we can.
Okay, thank you so much for putting all this energy and determination. As the immunosuppressed community is looking ahead, the telehealth has become critical, not just for continuity of care for our conditions, but also for a lot of comorbidities. So we're getting care over phone and video for many things. And looking ahead at the fall, this is a time when we're always already fearful for the regular flu and regular contagion. And there's one new thing that I didn't hear mentioned in all this time, but the current vaccination rates in Nevada are abysmal as a consequence of COVID. So the landscape that we're facing ahead in terms of our ability to circulate in the population, it's not just COVID that is a primary fear for people who have suppressed immune systems. So another reason to please go forward, and thank you so much.
Thank you.
Great. It looks like attendees, if anybody else wants to speak during public comment, please take the opportunity now to raise your hand. And Mr. Chairman, I'm going to turn it over to Ms. Mayville. I believe there is some written testimony that she's going to read into the record.
Yes.
Thank you, Leslie. Go ahead.
Okay, this is from Brandy Montanini, and she is a dental hygienist. And she's saying, on April 30th, the Nevada State Board of Dental Examiners adopted the DHHS memo that outlined guidance for dental services in a phased approach. This phased approach was carefully considered and approved under guidance from Governor Sisolak's medical advisory team for the resumption of non-emergency dental care. Although there were restrictions involved, specifically the restriction of using ultrasonic and piezo devices to deliver hygiene care. For a month now, many of my colleagues have been back to work trying their best to treat the patients in our community without the proper tools and equipment. And this is not only a very archaic approach, but a complete injustice to the citizens in our community. Additionally, many patients are being turned away because, as licensed, educated healthcare providers, we know that we cannot possibly treat their disease definitively without the use of ultrasonics or piezos. And I'm not sure if I'm pronouncing that right. Therefore, treatment is being postponed for these individuals, ultimately increasing their risk for lung disease, heart disease, diabetes, hypertension, Alzheimer's, obesity, pregnancy complications, and COVID-19. Our city is reopening. The casinos are even open now, but our dental community is at a complete standstill because we are lacking a full dental board to take that much necessary and overdue action to move us into the next phase. The next phase would restore our full function as dental providers and allow us the authority and ability to provide the complete and outright necessary dental care our patients and community needs and deserves. We simply cannot just sit by and wait for new board members to be appointed, as that could be months. Last year, we were without an acting dental board for over 4 months, and our community should not have to suffer during this state of affairs. I, along with my colleagues, plead that you take immediate action by making the imperative executive decision to restore our full scope of practice by moving us into the next phase for dental services. Thank you, Brandy Montonini, RDH.
Thank you for that testimony. Anything additional, Leslie?
We had something that says audio only telehealth services from Steve Messenger. And he says, hello, patient protection commissioners. The federally qualified health centers that comprise the Nevada Primary Care Association have radically changed their delivery models in response to COVID-19. As many of them rushed to provide direct-to-consumer telehealth services for the first time, audio-only visits were crucial to maintaining the link between patients and their providers. Now that they have all gained the ability to deliver audio-video telehealth visits, they are starting to get a clearer picture of which patients do not have access to video conferencing tools. I had planned to withhold comment to the commission until I had data to share. However, there has been such a good discussion in today's meeting that I wanted to let you know it will be coming. I expect to be able to share the percentage of patients who received audio-only visits out of the total of telehealth visits shortly and what this trend looks like. In the coming weeks, I hope to be able to characterize those patients by geography, race, ethnicity, income, etc. Respectfully, Stephen Messenger, Policy Director for Nevada Primary Care Association.
Good to know. That will be helpful to us. Any additional comments?
That's all I have.
All right, folks. Well,
just for the record, there's no other attendees that have indicated that they would like to speak.
all right. Hearing no other public comment, I think I would like to adjourn this meeting for the good of the group. Talk to you all soon.
Thank you.
Bye.
Goodbye, everyone. Thank you, Mr. Chair.
Thank you. Bye.
Bye.